And we are back with more What's Now, taking our attention to health and wellness, especially lung cancer. I recently spoke with two individuals who have had lung cancer and very different experiences and journeys, and they have some great insight. Let's take a look.
You've been diagnosed with lung cancer.
Welcome to Pentecostal Baptist Church. We're so happy to have you this morning as we prepare for this health symposium. We thank you for joining and engaging with us in this vital health conversation that we're having with our community on the vital and critical issue of lung cancer. In this workshop, we'll be dealing with the issues surrounding this dreadful disease as we prepare to inform our community and to enlighten them on the opportunities that they have to access health care in a manner that will be very preventative and will extend life. This workshop is important to the Black community because we are an underserved community that is resulting in health disparities for our people. This workshop will cover the history and risk factors and health disparities of lung cancer in communities of color, how prevention and wellness and transitioning lung cancer to the treatable disease, health equity, and improving access to multidisciplinary lung cancer teams of Black Americans. We'll hear from experts in lung cancer, primary care, patient navigation, and care providers, and get honest insights from a courageous lung cancer survivor. In your registration package, you will find some information relating to our symposium today And in there is a form that we need you to fill out. It's a survey that is related to the health issues that we will be addressing during the symposium, and we would like for you to fill them out. There are two forms. We have a pre-symposium form and a post-symposium form. We need you to fill out both of them so that we will have an accurate information to make assessments for how to address the issues that are related to this disease. I want to now turn it over to Dr. Stan Watson, the Director of our National Faith-Based Engagement for the Policy to Heal and Collaborate, to share the information about HEAL's mission, commitment, and improving the knowledge and understanding of our health in African American communities. But one thing I'd like to do before I do that, I forgot, I want to introduce our HEAL collaborative team and also recognize our sponsor, which is Amgen and Oncology, for the work that they are doing in this vital area. We had a wonderful roundtable workshop in Austin not long ago, and it was extremely informative and helpful, and I want to thank them again personally for the work that they did. Brother Watson was an extremely gracious host and organizer, and we thank him for his tireless effort and work, and honored to have him with us here this morning, along with Sister Lisa Phillips and her team, who are the drivers behind this effort. And we thank them so much for allowing us to participate in this vital service. We'll turn it over now to Dr. Reverend Watson, that he can share with us, right?
Good morning. Good morning. I was almost afraid to come up, Pastor Jefferson. You had called me doctor and now reverend. My dad's a reverend, but I'm just a deacon, so you scared me to death this morning on Saturday morning. I know I had a trial sermon this morning, but I appreciate the hospitality that you've shown us. Thank Pentecostal Baptists and Church under your leadership for all that we've done to work and partner together. Thank you for coming today, and we'd like to thank you this morning for taking out time on your busy schedule to come and see interactive panel discussion featuring medical experts, pastors, and policymakers. And we want to take an attempt to assemble the community to make sure that we can distribute the information that we need. The information will come from patients and collaborative partners, from the community leaders, and from healthcare providers. We're here today to discuss how we can close the gap in health disparities in the African American communities. And what better way we can do that when dealing with the institution that we have in our community, the African American church. We're here to partner with our church, not to take anything from the church. We're not at the gate asking for alms, we're bringing gifts. And our gifts is one of information about disparities in our community that we hope that you will take and share with your community. Share with your congregation, share with your community, share with your organizations, and most of all, share with your family. This information will be online, and we hope that it will help you. So on behalf of HEAL Collaborative, who works hard in the community to discuss and to bring attention to health disparities, to our board, from our board of directors and our hardworking staff, we'd like to thank you this morning for coming and working with us, and we thank you so much for that. I would be remiss if I didn't tell you that you just can't be hearers of the word. You have to be doers of the word. So if you hear the word today, make sure you share the word with your community, with your organization, and other disciples of Christ. Thank you so much, and good morning.
Thank you very much, Deacon Watson. And I'd also like to join in thanking Pastor Jefferson for hosting this most very important meeting here today. I want to remind everyone, those of you who are online, obviously have filled out the pre-event evaluation. For those of you here, if you see in your packets, there's a sheet there for the pre-survey. If you would be sure and fill that out, and we'll be talking more about that as we go on. This is, as already been stated, a very august meeting, and the purpose is quite serious. We all know the problems as far as lung cancer in the African American community, and it is something that we have some control over, and there's some things we can take over and some actions we need to take. To get us started, our first speaker is Dr. Eric Flanneau. Dr. Flanneau is a graduate of the McGovern Medical School at the University of Texas Health Science Center here in Houston. He did a residency in internal medicine at the University of Texas Health Center, and followed by a fellowship in pulmonary and critical care medicine, also at the University of Texas Health Science Center. I guess you found a good thing, Eric, and you didn't want to leave it. Currently, Dr. Flanneau is the Associate Professor and Vice Chairman of the Department of Medicine at Morehouse School of Medicine in Atlanta, Georgia, and he's Chief and Director of the Pulmonary and Critical Care and Interventional Pulmonary Medicine at Grady Memorial Hospital. Perhaps more importantly, though, for those of you who don't know, Dr. Flanneau is a cover boy on a magazine. In 2020, August of 2020, he was named one of the top docs in Atlanta, and quite seriously, for the wonderful work he led in leading the response for COVID-19. And for that, he is to be commended, and that's a very good recognition. Dr. Flanneau will address today, what is lung cancer? It is not all smoke, lung cancer incidence, and health disparities. Dr. Flanneau.
Thank you, and thank you, Pastor, for allowing me to come here today, and thanks to the HEAL Collaborative and Amgen for allowing me to do this and speak to something that's really close to me and really something I'm passionate about. So I want to talk about lung cancer or healthcare disparities, but in doing so, I want to change what we think about healthcare disparities and how we think about it. A lot of times when we say healthcare disparities, people automatically think, oh, it's basically race-driven, and it's not always race-driven. There's other factors which play a role in it, and so I want to break that up and divide it into two areas. That the disparities that we see with respect to lung cancer deal, one, with health, and those may involve environmental factors or the natural biology of people based on ethnicity, race, sex, age, and then there's another part that's health care. And that's factoring in things like early detection, prevention, treatment options. And we put those into those two contexts. We can think about it in terms of the causes and how to address it and moving forward with respect to the treatment. So when we talk about health, the health part of it, let's talk about that for a second with respect to environmental factors such as smoking or radon exposure, and biology, which is a susceptibility of different people to the tobacco smoke or the other factors which may play a role in the development of lung cancer. So, very importantly, African Americans, they have the highest U.S. cancer mortality rates despite similar smoking rates. I want that to sink in a little bit. Highest mortality from lung cancer, similar smoking rates as whites. And these are statistics for African Americans. So you have, if we looking, I don't have a pointer here. So if we look here in the top, you see on the top line, you have the estimated new cases that we expect to see in a year. And on the bottom half of this, you'll see that there's differences or the estimated deaths that you expect to see within a year. And we have male and female separately. So if you look at the estimated new cases of all cancers in African Americans, you're going to see in men, prostate number 1, lung number 2. And then you see colon cancer and kidney, which we need to pay attention to, but just look at that relationship. And for women, breast is number 1, lung is number 2. And that's what we expect to see. And that if the numbers actually show that the incidence of prostate cancer about 3 times that it is lung cancer in men, and about 3 times the same, breast cancer is about 3 times more than lung cancer in women. If you look at the deaths, though, lung cancer jumps up, right, for men. So it's killing more people despite being not as prevalent in men. And for breast cancer, if you went back 2 years ago, lung cancer was above breast cancer. Right now, it's just about equal. So it's telling you something that even though breast cancer and prostate cancer are about 3 times more prevalent, lung cancer is still killing more, right? And this is in our patient population. So we have to think about this and why is this and why are we seeing these patterns from that? So I talked about, despite equal smoking rates, that the incidence is higher. And this is just to depict it for you. So on your, I got to get my left and right here straight. So on the left-hand side, you'll see the incidence rates. And these are the number of cases that happen per 100,000 people. Okay. And you'll see African Americans, there's about 74.7 versus whites, 64, and then Native Americans and Native Alaskans, about 44. Right? So clearly, we know what we've seen and what you've heard already is that African Americans have a higher rate, almost 17% higher rate of having lung cancer. But when you make the comparison of, well, do they have this because they smoke more? Well, no. If we look at this, you'll see at the top, you'll see African Americans, the yellow is men and the darker color is women. And you see it's only about 25, the prevalence rate, or the percentage is about 25% of men, 18% of women. And for whites, it's 23% men, 20% women. So there's not much difference there. These are almost equal statistically. And even a bigger question comes up is look at Native Americans and Alaskans, smoking almost twice as much, right? But if you go back to the incidence rates now, you can see that there's clearly a difference. So what this is telling us, all the numbers and everything, what this is telling us is that there's something about the susceptibility, the bad effects of tobacco smoke puts African Americans more at risk to suffering the bad consequences of tobacco smoke than the other races. So there is something genetics, there is something ethnicity or race based on there. And this is what we have to keep in mind as we start thinking about prevention and the importance of it all. But there's another thing that we've learned, especially as I've been treating patients and evaluating them for a long time. It's not just how much you smoke. You go to the doctor and say, okay, how much do you smoke? How much do you smoke? And we've actually had to learn, we need to ask a different question is, what do you smoke, right? Because that starts to play a role. And we've seen this. There's new things that are out there, new trends that are going on there, legalization of marijuana that's coming out there. And there's a lot of other factors, especially in our community, that play a role. And they're smoking a lot of different things. There's the tobacco use that's hand-rolled or self-rolled, the different types of paper that are used. There's now the electronics. There's a trend of hookah. And now marijuana is starting to become more prevalent because it's starting to become legalized, especially in different communities around the state, around the country. And then the electronic cigarettes as well. So there are some untold truths about these that people think, okay, well, yeah, I smoke a little marijuana every now and then, or I don't smoke a lot of cigarettes. I don't smoke cigarettes. I just smoke 1 or 2 Black and Milds a day. Well, there's some untold truths about this. And what they don't realize when we start asking about, how much do you smoke, is that, the small cigarettes, usually cigarettes have about 8 milligrams of nicotine in it. And this is just a comparison because it's measurable. I want you to keep in mind one thing. Nicotine is highly addictive, right? And that's what keeps people going back to it, okay? If it wasn't so ingrained in our history and government that if it were to come out today, it would probably be highly regulated by the FDA, right? Because it's that addictive, but it's not. But that's what keeps you coming back. But it's the other 6,000 products that come from burning of the tobacco that actually contribute to lung cancer. So it hooks you, the nicotine hooks you in, and then you're exposed to all these things, and this is what carries it on. So cigarettes have about 8 milligrams of nicotine in it. The small cigars, the Black and Milds or so, they have about 100 milligrams. So that puts you at, because a pack is about 20 cigarettes, so that puts you about a pack, or about 15, almost, 3/4 of a pack, right, in just one Black and Mild, okay? And if you get the bigger cigars, then you're getting almost up to, a pack and a half or so. So just saying that I smoke 1 a day, or I might smoke 1 or 2 a day, means you may actually be smoking 3 packs a day, 2 packs a day, just on this. And this is something that I don't think is very well known, especially amongst the younger population, where we're starting to see more and more use of these cigars and these they call them cigarettes or cigarellas. And then the hookahs, right? And there's been, big trend of hookah bars, hookah lounges, and everybody goes out, oh, we're going to go and we're going to smoke it, in one of the hookah bars. Well, a hookah session is more harmful than smoking a pack. Okay? Usually the hookah sessions, they last about an hour, okay? And people are passing around, that's kind of gross, but they're passing around these things, everybody's smoking it in and whatever else. And they figured it's about 200 puffs per session. And what that comes out to be is about 100 cigarettes per session. Okay, yeah. So that's about 1.3 cigarettes per minute is what they're smoking. So you can rack up your tobacco exposure just in a few sessions a week. Oh, we just go once a week or something like that. No, you're getting a lot of tobacco smoke. And I don't think that's what people really understand. And then there's the marijuana. And say, oh, yeah, and we hear our patients, oh, yeah, I smoke a little marijuana once, twice a day or something like that, just to relax me and something like that. But there is a relationship between cannabis use or marijuana use and lung cancer. And it's about a twofold risk for those that have heavy marijuana use. So you're asking yourself, what is heavy marijuana use? Well, they've looked back in this study, they watched over 40 years to figure what that risk is. And that's just heavy use is more than 50 times in a lifetime. It's not in a month, it's not in a year, it's not in a day, it's in your lifetime. If you smoke marijuana 50 times, then you're a heavy user. So you're at a risk that's almost twofold of developing lung cancer. And these are things we need to take back and educate, those around us, or even ourselves, about the uses of what you're using and how it plays a role into developing of lung cancer. Because we want to get into a point where we decrease some of these health disparities. And the only way that we can decrease these health disparities is by knowledge. What we call is health literacy. And so this is to help get out and get some of that information there. So a little about health care, right? Because this is the other side. We can talk about the biologic aspects, the environmental aspects, but there's another aspect, and it's health care and what's available out there for you to improve or help you improve some of these disparities. And so we think about early detection, systemic factors, and then we'll talk a little bit about some prevention there. So health versus healthcare, we're talking about African Americans are less likely to meet the screening eligibility criteria compared to whites. Okay. And this was something that we've actually looked at pretty heavily in our institution here. And when we talk about screening, you're going to hear about screening a little bit later, so I don't want to go too deep into it. But we think about screening for breast cancer, which we know saves lives. Screening for prostate cancer, which we know saves lives. Screening for colon cancer, the same thing. Screening for lung cancer can do the same thing. Because when we are screening, and this is the word we got to get out, screening is checking for cancer before you have any symptoms. Okay? And it's done with a CAT scan. That'll be talked about a little bit later. But there's two big studies which have shown that if you get screened for lung cancer when you're at a high risk of it, decreases your chance of dying from lung cancer between 20 to 25%. Okay. So just the simple screening process of getting a CAT scan once a year can actually decrease somebody who's high risk for lung cancer of dying by 25%. That's 1 in 4. 1 out of every 4 people will improve or improve their risk of dying from lung cancer just by getting screened. Okay. So what we looked at initially in 2015, the original screening criteria came out, and they actually had the years, the amount of time that you had to smoke, which we say a 30-pack year. And basically, that's you smoke 30 years, at least 1 pack a day, or if you have smoked 2 packs a day for 15 years, that would be 30-pack years, right? So you met that criteria, you met the age criteria, which was 55 to 80, and those were the original recommendations that came out for screening. But when we're in our hospital and we're seeing people, and in our hospital we see about 80 to 90% of our patients with lung cancer are African Americans, and probably a little bit higher than that. We noticed a trend. And on that trend, we were seeing that I would have patients come in at 29, 34 years old, they have stage 4 lung cancer. Okay. And when we went back and we looked at all of these patients, we said, well, they wouldn't have even met the age criteria to be screened. They didn't have a chance. And we went back and we looked at the data, we found it was 11% of patients that we knew had lung cancer didn't even have a chance of getting screened because they didn't meet the criteria. And 6% were above the age. So 11% under, 6% above. That's 1 in 6 African Americans would not have even met criteria to get screened. So they didn't have the opportunity. So we published that. A few of those later, there's a couple other studies that back that and then recognize what I mentioned to you earlier, is that even though you smoke the same, you're at a higher risk. So they changed the smoking requirements too, so we can get more African Americans in. I still don't think we're where we need to be. We're getting closer, but it does tell us there needs to be an importance on the amount of screening and going for the screening in order to help decrease some of these disparities. So screening has now become common practice. It's a standard practice in the medical field, and states are actually ranked by their screening criteria. So when you look at this, and I'm pulled up specific data for Texas, you can see that Texas screening, even though we know that it's a standard and it saves lives, they are not doing very well here. Okay, so in Texas, only 2% of those at high risk for lung cancer were screened. Now, as a nation, we're not doing very well either. It's only about 6%. But that puts Texas down around the 48th state. So they're just hovering above a few other states there. Okay. Another component is African Americans are diagnosed at a later stage. So you got to think, if we're not screening very well, if we're not going for the follow-up, then we're going to get missed. And by the time you get diagnosed, you're going to have a later stage, so which means it's spread even further. So looking at the distribution here, I want to show you, and this is how we kind of think of it. Localized lung cancer, it's in one spot, okay? The regional means it may be in the lungs and some of the lymph nodes, but it hasn't spread to the rest of the body, and then the distance means it's spread to the rest of the body. Blue is whites, reds are blacks, and you can see that blacks less likely to have early stage disease where it's just localized in one spot, because that's the easiest to treat. Just go and either cut it out or you do some radiation and it's done. Regional, it's kind of matching up, but we're more likely to have late stage disease that is spread through the body, which gives you less opportunity to achieve a cure. So screening is extremely important, because lung cancer in an early stage, you don't know. It doesn't have any symptoms, right? It's the later stages that you have symptoms. So by the time you have a cough, a persistent cough, or your shortness of breath, or you're coughing up blood, you're losing weight and you can't explain, or you're having recurrent infections, okay, or pain in your chest, by the time those symptoms develop, 75% of the patients with those symptoms have late-stage disease, the distant disease. Okay. So in Texas, and this, what you're seeing here is the national data. Remember, we broke it up differently there. We had the local, regional, and distant disease. And this is looking at the 5-year survivals. So the best 5-year survival nationwide you're going to have is if you're caught in that dark blue section, right? Because that's the local disease. As it starts getting further out, and you get regional into the purplish color, then your survival starts decreasing. Only 34% of those patients diagnosed at that stage were still alive in 5 years. And further out, it gets less. So it's extremely important for the screening to occur at an early stage there. Only 23% of cases here in Texas were caught at an early stage, which is less than a national rate of 26%. Okay. Texas ranks 43rd of the 49 states that were in the survey for being able to be detected at an early stage. But I will say the good point is that over the last 5 years, because screening has occurred here in Texas, that those studies, those numbers have increased by like 9%. So it's working. We just need to make it work more and work more for our community. Okay. And so the last little section is did African Americans have a lower likelihood of receiving standard diagnostic, staging, and treatment options? And this is important. Remember I talked to you about if it's localized, that early stage cancer, if it's in one spot, the easiest thing is have the surgeon go in and take it out of the body and it's done. Well, this is a study that looked at different races and different sexes to figure out who's getting that early stage curative treatment, right? And if you look there, white men, 93%, white women, 90%. Even African-American women, 90% are getting the treatment needed to get them cured for early stage cancer. African-American men, 65%. Okay? So we have a target. We have a population we need to focus on. Okay? How is that playing out here in Texas? You're going to see the dark blue is white Americans, the light blue is African Americans. African Americans were 15% less likely to be diagnosed early here in this state. Okay. They're 19% less likely to receive curative surgery. Okay. They're 10% more likely not to receive any treatment at all. Okay. And 12% less likely to survive for 5 years if they have the diagnosis of lung cancer. But it's interesting because the studies have shown, and you're going to look here on the left side, we're comparing blacks and whites of all lung cancers, or of all stages of lung cancer, and their survival over 5 years or 60 months in time. And you can see that whites were surviving more, right, than African Americans. But for those that had early stage, that could be cured by surgery, that when they did get the surgery, that difference disappeared, which means similar treatments will give similar survivals. Okay. So a little bit about biomarker testing and what it is, and because this is a big topic that's coming around. So you're going to hear a lot about this. So biomarker testing, what they're looking at from the lung cancer is they're looking at those DNA, part of the genetic DNA mutations inside of lung cancer that help it either grow, help it thrive, or provide its own blood supply. And by testing for those, there are now treatments that can target those, so you can stop the cancer from growing, stop it from thriving, and stop it from developing its own blood supply so it continues to survive. And so that's what we call targeted therapies. It identifies those unique characteristics in the type of lung cancer, and so they can target the therapies directly towards either the development, the growth, or the blood supplies, and that actually helps have a better response to treatment, and it's different from just having the standard chemotherapy and radiation. Standard chemotherapy and radiation is pretty harsh on the body. A lot of these therapies are just maybe a once-a-month infusion, or it might be pills that they take, and it's actually been shown to improve the survival. And fortunately for lung cancer, there is about 35 new treatments that can be provided when they're able to identify which markers to target through biomarker testing. Okay. The sad part is that only about 14% of blacks receive biomarker testing versus 26% of whites. And I think that this is an opportunity for us to move forward, because if we can get the biomarker testing going, and if we can get those treatments which improve survival into our population, remember what I said earlier, equal treatment gives equal survival. So this is a direction that I think we need to move forward with. Give you this soon. But what else do we need to do? It's always great to look for screening, early detection, and treatment. The other thing is we got to look for prevention, okay? And this is where I think that community activism can come into play. Churches can come into play. Because nobody starts out saying, oh, I'm going to smoke and I want to be a long-time smoker and I want to end up on oxygen, whatever else, 20 years from now. It's usually I just do it to be cool, or I did it to hang out when I was hanging out with friends, or I'm having something to drink. But the other thing is that the kids see this, right? They learn not from what you tell them all the time, but what they see you do. And this is where we need to go. So this is 2022 data looking at middle school students and high school students because they're smoking. And this is what they're smoking. I'm going to have to blow this of you. So top line is any tobacco products in middle school. About 4 to 5 out of every 100 kids are smoking in middle school, right? Girls at 5.3%, boys at 3.8%. So the girls are actually outdoing the boys here. Electronic cigarettes are number 1, Cigarettes are number 2. And now you talk to some of the kids, yeah, I get them from my parents. I steal one from them. Cigars, number 3. Okay. For in high school, a little bit of a shift, but it is about 16%, so it goes up because once they start in middle school, they continue to smoke and they get around their friends and it passes on from that standpoint. And it's for girls, it's about 17%. Okay, for boys, it's 15%. Okay. So, you used to say, okay, the boy's doing something stupid, it's usually because there's a girl around, right? Right, we're trying to impress them, but now there's been a shift where now the girls are starting to outperform the boys in this, and it's usually electronic cigarettes, cigars, and then the normal cigarettes, and a lot of it comes from the menthol-related cigarettes and the flavored cigarettes, and the tobacco companies know this, and this is the point where we have a lot to reach out, start getting some activism going and some education going. So with that, I'm just remember, we have a target population. It's never too late to quit. It's never too late to prevent. It's never too late to get screened. Thank you.
Why don't you come over here to the panel thing? Okay. Pastor Jefferson, I want to compliment you here at Pentecostal Missionary Baptist Church. First off, it's a beautiful facility. But I'm impressed with your team. I know you give the word, but your audiovisual and IT services obviously help you get the word out. So I want to compliment you for that. And thanks also to the folks who are helping us with that. Our next panelist, and we're going to have Dr. Green come up here and join us. Dr. Green is a primary care physician, internal medicine by training. He graduated from the Baylor College of Medicine and also did a residency in internal medicine at the Baylor College of Medicine. He is a primary care physician and currently is working with the Surtee Medical Primary Care Center. Dr. Green and Dr. Flanault will be here for questions, but let me start things off. Dr. Green, from what we just heard what Dr. Flanault just talked about, would you tell us a little bit more about the role of the primary care physician in screening for lung cancer? And in your answer, if you would talk a little bit about how you incorporate screening protocols and then manage that data, and then how do you, which being the primary care physician, help as far as compliance, getting the actual test done, and getting the patients their outcomes.
Thank you. Good morning. My name is Dr. Demetrius Green. Of course, the name of my practice is SurtMed Primary Care. I'm off the 610 loop between Buffalo Speedway and Kirby. Now, as you're saying, with lung cancers, the biggest thing with most cancers, especially like with colorectal, breast, prostate, is screening. And of course, nowadays, there's a certain standard of care. And all screening should start with your primary care physician for those who have one. I mean, you should be able to get your yearly physical. And usually what a primary care does, like I say, does a screening. And with my patients, I look at their risk factors, okay? For instance, if I have someone who does have what you call at high risk, those who with tobacco use 20 plus years, exposure, they talked about radon, and of course, working in certain industries where they have exposed to certain chemicals or who are exposed to secondhand smoke. You can start your screening with what you call a low-dose CT. Okay, it's a CT scan, and it is covered by your insurance company. Most all screening tests are covered, including breast cancer, colon cancer, prostate cancer. But getting back to lung cancer, you would do it at least once a year. And as a primary care physician, I need to target those patients who are at high risk, especially during the physical exam. You don't have to wait till the physical. You can do it any time during the year. And that is, find out how much they smoke, how long they've been smoking, and of course, just go ahead and find an imaging facility. You have St. Luke's, you have Methodist, and other screening facilities out here, healthcare facilities that can actually do the CT scan.
Thank you very much.
And one more question. And of course, with me, my goal is once I get those results, I look at those results and determine, is there anything suspicious, if there's a mass there, or if there are any follow-up studies needed.
Thank you. If any folks here in attendance would like to have a question, please let me know. And of course, if you're online, just get that information and we'll try to get your answer. Yes, please. Hold on, please. Let me, okay, good. While he's waiting to bring, I'm going to ask something of Dr. Flanault, then I'll come back to you. Dr. Flanault, you made an interesting point about the differences in survival for African Americans versus whites. even though they're smoking the same number of cigarettes per day. Could you comment, number one, you talked a little bit about the B&Ms, the blacks that folks are smoking, but you also talked about the role of some other different brands of cigarettes that folks are smoking. And also, could you comment on the role of pollution or toxic material that people are taking in? Because clearly African Americans tend to live, there's that element of environmental racism which has to be compounding the problem.
Right. So there's been studies which have shown that the environment that you're close to, if you're living near some of the trash dumps facilities, near factories, those actually do impact in terms of exposure. Now, the exact exposure varies from city to city and what the exposure are, but the environmental facilities should be checking into that and seeing. We know in the Northeast, there's a lot of BPA's and phosphoric products within the soils that are play a role. In highly industrialized cities around the world, we've seen that lung cancer incidents are actually increased. And then your other part was about?
Big thing. Remember, there was the old thing with cools, menthol cigarettes
Yes.
versus non-mentholated, how African Americans, being cooler in general, tend to smoke these mentholated cigarettes.
And it's actually, so the tobacco companies knew exactly what they were doing, right? And they know exactly how to target people. And African Americans did prefer the mentholated cigarettes. So much so that it's about 90% of the cigarettes smoked by African Americans were there, and it was targeted. Actually, they marketed to those specific areas. Recently the Biden administration has passed legislation where they're getting rid of the menthol cigarettes. So hopefully we'll see that go away. But then they've made a little bit of a different shift. Some of the Black and Milds and other cigarettes, they're actually flavoring them with different flavors. And this is to target younger populations. We saw the same thing with the electronic cigarettes, right? They have different bubblegum flavors, cinnamon flavors, right? Just to attract younger people. Because they know once they can get you started and get that nicotine in your system, it's highly addictive and it's going to keep you coming back.
Gotcha. Yes, ma'am, please, your question. And could you state your name for us?
Janice Jefferson. I'd like to know from the primary care physician, you said something about when you do the, appointment exam, however you want to describe it, you automatically order some tests. For example, colonoscopies,
Yes.
Breast cancer, your mammograms, etc. Why isn't it that you just don't automatically order the screening for the lungs as you would do? Is there a particular roadblock?
As I say, it depends on your risk factors, okay? And sometimes it can be to the insurance companies. As I say, screening tests should be covered by your insurance companies, but I've had some pushback just getting, a low-dose CT scan for somebody who smoked for about 20, 30 years. But it has to do also with the clinician, their inertia. So it's like when you come and I look at you, I say, what age, what category you falling into? And then that's when I decide, okay, should I screen for this, should I screen for that? So depending on your risk factors, your age.
Why risk factor?
Okay.
There's, I'm sure, incidents of different ailments, such as the breast cancer. There's no history in my family, but I still have to take the mammogram. So why do you have to look for risk factors? Why isn't it that if you meet a certain age, you just go on, okay, and I'm going to order this, even though I don't have the risk factor? I may meet the age requirement, but I don't have a risk factor in my genealogy that would suggest that I would have predisposal to breast cancer. Why can't you just move forward with that?
Well, what it comes down to is down to standards of care. As physicians, we follow what we call standards of care. They will tell you at what age should we screen for certain things. For instance, I recommend we screen at age 40 for breast cancer. For men, they recommend age screening for prostate cancer age 50. And of course, like I say, with lung cancer, you have the American Cancer Society and of course the American Thoracic Society decide, okay, what would be a legitimate age, what would be a proper use of resources, because you don't want to screen everybody that come in. You're not going to screen a 25-year-old, 30-year-old, who's going to smoke for a couple of years, because they say you're going to find a lot of false positives, and of course, you don't want to miss a false negative. So we're going to say, where's your high risk and where's your most likely to be able to find that diagnosis in that patient?
Let me just, because I think we might be able to get Dr. Flano. Let me ask you this first, though. Dr. Flano, addressing her point, tell me about what the current recommendations on the Preventive Services Task Force, is saying? What does the data actually tell us?
So the current recommendations are if you're between the ages of 50 and 80, right, and you have smoked at least 20 pack years, which is I've smoked 1 pack a day for 20 years, or I've smoked 2 pack a days for 10 years, or, you know, just do the math, and that you have smoked sometime within the past 15 years, then that's the criteria that they say that you will qualify for screening for lung cancer. Okay? There's other things that play a role, you know, they're healthy enough to go through this, they're healthy enough to go through treatment, and that they're going to follow up, because you're expected to continue that screening with the once a year until you have stopped smoking for at least 15 years or you get outside of the age limit. But that's the criteria there. So now, why is it like that? Is because they based it off the original study, and then that was the population that benefited the most without breaking the healthcare system because of the CAT scan, the cost of the CAT scans. Now, it's covered. You're not being billed for whatever. If you have the health insurance, it should be covered through that, and Medicaid, Medicare, and CMS will cover that. The problem is that it's estimated there's about 50 million active smokers in the United States and 50 million former smokers that would qualify, and that would be quite a bit. And so what they were looking is to try, how can we catch the most and still be able to continue to provide it financially across the U.S.
So the dollar is the bottom line, from what I'm hearing.
In part, yes, and that's the way it is everywhere.
Healthcare is, well,
yeah.
I can't remember which of you, and I think it was you, Doc,
Yeah.
who said that 25-year-olds were being screened at some, okay.
Yes. So let me tell you. So here's the thing, and I think this is where we as a community kind of need to move forward too, especially with education and learning exactly where we stand. So that study looked at like over 20,000 patients, whatever else, and they did all this, and that's where they, out of the big national lung cancer screening trial, that's where they came up with the guidelines for this, and they figured out, okay, these are the populations most at risk. But it was missing the African American patients in reality. So why is that? Because there's about, at the time of the study, the African American population was about between 14 and 16% of our population in the United States. In that study, it was 4%. So there's two aspects. So the study didn't enroll. Now, some of it is a lot of African Americans aren't going to go into any studies. That's in their mind because of bad history. I think that we need to get past that a little bit because things have changed and regulation has changed. And then enrollment, some of the studies were done in areas that didn't have a lot of African Americans. What it does show us is that if we're not part of these studies, then we get left out of the recommendations and treatments that are going to be available for us.
We need to get past the Tuskegee Airmen.
Yes.
That's probably what is holding us up.
And let me correct you on that. It is the United States Public Health Service study on untreated syphilis in men in Tuskegee. That is the actual name of the study. So it should not be the Tuskegee syphilis study. It is the United States Public Health Service.
Yeah.
And the reason I mentioned that,
study.
no, the reason I mentioned that, because let's go to another point. Right now, to your issue, screening is covered by all insurances because of the Affordable Care Act, or also known as Obamacare. Down here in Texas, you have a judge by the name of Reed O'Connor, who is the single federal judge in this one little area who has just invalidated, Judge O'Connor is the same guy that did the thing as far as the birth control, or the abortion pills too. Judge O'Connor has now invalidated the provision in the Affordable Care Act that covers screening, saying that it is an unfunded mandate. So what impact do you think that this is going to have? And to your point, in terms of action, the same vigor that you're bringing and raising these questions, this is the sort of action that we need to take, and how is it that this one federal judge is going to throw a wrench in the entire screening process? Not only lung cancer, colon cancer, breast cancer, prostate cancer. So what do you think might happen if this does, in fact, carry through and reach up to the Supreme Court?
What's going to happen is this: it's definitely going to impact communities of lower economic and low economic status. The reason why, because it comes down to health care. You know, like I said, the United States Preventive Services Task Force, the American Cancer Society, American Heart Association, they actually set the guidelines how to approach and how to treat certain diseases. And a lot of times, you're right, sometimes it comes down to finances. What's going to be the most futile and the most economic reason to spend our resources? Because, you know, healthcare is booming, okay? Because we're living longer, and of course, people are living longer with more chronic illnesses. But getting to the point, what he was saying is this: when it comes down to costs, you know, I trained at Methodist, St. Luke's, Bentab, and the VA. So it gets you to think. I saw how it was actually applied across different levels of economics, race, and socioeconomic status. So if I'm working for a big company, I have good insurance, I'm going to my doctor, he's going to make sure I get my screening. But what if I'm going to my Bentab, okay, my LBJ, my Grady's, my Cook Counties, where of course looking at a government institution, they're going to do their best to do what? To start to save money. So if they say it's not recommended, they're not going to do it. But if I'm at the Ivory Towers, okay, and of course where I'm at Methodist and St. Luke's, where of course, you know, they are for profit at times, they're going to make sure it gets done.
Unfortunately, some of those private insurers are going to stop covering it because they're no longer mandated to do so. Yes, ma'am, question.
Shan Miles, my question is, when you go get your annual physical, should we request from our primary physician to do a lung cancer screening?
Yes, you can request when you go, and you can ask them. You know, if you have notes. You know, a lot of people tend to go on internet. You know, you got these Google-licious people. You know, if you have questions, write them down and ask them. Say, should I have this? Should I have that? Because sometimes, if they have 20, 30 patients out in the waiting room, sometimes things tend to get split open. Not that they're not doing their job, because sometimes they get rushed through. But you, as a patient, just like when you go to the store, you go to a restaurant, you're paying for a service. You want to make sure you get what you came for.
Yes, please.
But in doing so, you can go ask, I would ask them, do you meet the criteria? And make sure that they're evaluating criteria. Because what they don't want to do is start screening outside of the guidelines. You can only deviate about 10%, then they're going to get kind of shut down or dinged for doing that. But what we need, and the information we've got to get out, what we need when we see these patients, we're asking them, is to be straightforward. When I showed a picture of, we need to ask not only how much do you smoke, but what are you smoking? That needs to come out. And a lot of times there's a stigmata that comes with smoking, right? And then people just a little bit, they know it's not socially acceptable anymore, it's not the cool thing. And so they play it down, right? Don't play it down with us, right? We need to know exactly how much, when, what age, so we can actually do the calculations and make sure that you meet the criteria. And men are probably the worst. And I've always tell, so women, if you know your husband's, if you know your husband's smoking and you want to really look out for him, I tell the guys that if you don't want me to know something, don't bring your wife. Right? But bring them, because they'll let you know.
Let me ask you another point, though. I think it also gets to this. Could you comment, if you would? We know that there are various risk factors for the development of lung cancer. We know that there's the individual who is the primary smoker, but then there's also something, secondary and tertiary. Then also, so we know that someone is living with someone who's a smoker. Does that increase their risk enough to justify screening? And also, what about radon exposure? And then finally, again, that person who's living in areas with PFAS and all these other things. Is that not a criteria where you can say, hey, this person actually is at increased risk?
So we know that there's increased risk. We know that secondhand smoke.
And define what that is, please.
So yeah, secondhand. So the person actually smoking, they're smoking whatever they're blowing out or whatever's burning right next to you. You're inhaling the same thing, and sometimes it's actually worse. Okay, and so there is a significant exposure. A lot of the same chemicals which are developed can result in the development of lung cancer or any other cancer. You're actually inhaling it more. And the thing about that is the person smoking, if it's a cigarette, a lot of times there's a little filter in there that's in there. You're getting the unfiltered stuff that's coming back out. So it is significant. The challenge with recommending screening based on it, it's hard to quantify. So sadly, when it comes down to the dollars and who should and who shouldn't, it hasn't been defined. But we know that there's an increased risk. We know that people that get secondhand smoke and someone else develops lung cancer, they're at an increased risk of developing it. But the other thing is, there's other factors or other diseases that result from that. The kids, the tertiary, right? So they're getting asthma, they're getting ear infections, and they develop long-term lung disease. There are people that develop COPD, you know, and they weren't the smokers, but they had enough secondhand smoke to develop the COPD. And then there's the other diseases, that, you know, heart disease, risk of stroke. All of these come with tobacco smoking.
I'm sorry, Dr. Green.
I want to make a comment about, we're talking about, you know, when you come to the doctor. As you know, there are some patients out there who will not tell you they're smoking. The reason why, because it will affect their health care and their insurance costs, especially when it comes down to life insurance. So they'll tell you no. In the meantime, you know, they may be smoking 2 or 3 packs a day. So, and it's good, you know, for them to be honest, but at the same time, they're doing themselves a disservice.
But Dr. Green, you know, as a physician, you use all your senses, and, you know, sight, touch. We ain't tasting things like we used to in the old days, but you also do smell.
Yeah.
That person who comes in as a cigarette smoker, you know that they are smoking. Do you broach that subject to them?
Yeah, and sometimes you can do that. And just that you know, there is a test that you can do to determine if somebody's using tobacco. Okay, there is a test. You know, of course, a breath test. There's also a blood test you can do. Just to let you know, for those who out there, you know, they want to cheat. You know, insurance company has a way of getting around it because they can order a certain nicotine serum, a serum nicotine, to see if that nicotine is in your system.
Wow. Yes, ma'am. Please state who you are.
Joyce Coleman. This wasn't my question, but it's good you brought up that. I work at Methodist Hospital. They do their screening every single year, and if you show no nicotine, your insurance rate is higher. They charge you more. But here's my question. So I've never been a smoker. I feel like I've never been exposed to secondhand smoke. I don't work in an environment where the pollution is all of that. So but I do meet the age criteria for that. So should I even be asking for a lung cancer screening just as part of my screening process at all?
Well, you can, but you ask yourself, you know, do you have the resources to get it done? Because when they get ready to run their test, like I say, you can use, like I say, I know they have biomarkers out now, but I use what you call a low-dose CT. When I order that test, what they're going to do, they're going to say that this patient qualified before we pay for it. If I say, yes, this patient is a 20-year past history of smoking, yes, they will pay for it. If I say no, they would deny it.
They would deny it. So it's true that insurance sometimes will
take you up on that.
dictate.
Hold on a second. That's right. So would you comment, because it's something I want to make sure we don't leave, then why not just get a chest x-ray versus the CT? Is there really that much greater yield with one versus the other?
That was a point in time they did recommend a chest x-ray for those who are smoking, but it's not as detailed as a low-dose CT scan, because a lot of times, he may even tell you the statistics, I can't, but there are a lot of cancers that can be missed by a simple chest x-ray.
Yes, ma'am. I'm sorry. No, please.
Oh, no, it's fine. I mean, he answered, it's just as far as the chest x-ray as opposed to the CT.
Yeah. Well, it's not recommended anymore. It's not part of, you can still get it, but it's not part of standard care.
Right.
So it won't be considered a screening. It won't be considered a screening.
And I think it's important we make sure that we ask for that and not get that chest, just a routine chest x-ray. Yes, sir. Please state your name.
Michael Thomas, and piggyback off of what Joyce just said, if you were outside of the standard and the criteria and you went to your primary doctor and asked to get a test, a yearly test.
You can get it done. You just pay cash for it. You just pay for it out of your own pocket.
But what if someone, is on Medicaid or doesn't have the funds? But if you wanted your doctor, your primary physician, to do a test, could you just walk up to him and ask him, look, I would like to get a test, a screening, just to make sure nothing is wrong?
You can ask, but like as the doctor said here, if you don't fit the guidelines, the insurance company will deny it. Okay.
But what if it was previous, like in your family history?
Oh, yeah, if you can prove there's a family history, because right now, as you say, when you come to screen for lung cancer, family history of lung cancer is not in the screening criteria, okay? It's unfortunate because if I have a family history of colon cancer, yes, they will recommend a colonoscopy, okay? And same thing with prostate cancer, but why they don't put the same thing for lung cancer as they do with breast, colon, and prostate, the jury's still out on that.
But if you went to your primary and kind of insisted on getting that test because of family history, would your primary doctor be required for you to get that test or recommended to get that test?
You can order, I can order any test you want. I mean, I can order, say, hey, if you have chest pains, I can say, go do a cardiac cath, but will the insurance company pay for it? It comes down, who's going to determine the cost, because they want to make sure that, doctors are just not there just ordering tests, just to, to make money. Because, like I say, everything has a price.
I want you to keep in mind, though, that this is something that's developing. I mean, between 2015 until 2021, the criteria changed because they realized that one screening, one criteria, one shoe didn't fit all. And so as we go through this and more then we might see trends, and we're going to see something else is coming up. We need to make another adjustment. We need to move this forward. So I understand what you're saying, Professor. A lot of it is limited to what's going to get paid and what's going to be covered and whether or not you're going to pay out of your pocket. And so just keep that in mind when you're asking. But this is a changing thing. We're finding out more, and as more and more African Americans start getting into screening, we're going to get more information, and we're going to make a change so that what's being done actually reflects and benefits us as well.
Let me ask you, before we go into the next question, please. We've heard a couple of people say family history in talking about lung cancer. Now, we know clearly that family history plays a role for breast, prostate, colorectal, uterine, pancreatic, renal cancers, as well as some environmental factors, too. Is there a clear-cut genetic predisposition with lung cancer, or is that more an environmental? What is on the outside that we're breathing in and the cigarettes that we're also breathing in?
Family history and people and families that have low smoking or no smoking histories is extremely significant. The challenge, I'm not saying a problem, the challenge is that about 95% of lung cancers are related to smoking. And so it's really hard to tease out that person that would already have a higher predisposition if they're already smoking, right? Because if you already had a high predisposition and you never smoked, then we know, okay, that's family history there. But if there's a tobacco use history in there, it's always been said, oh, well, they smoked, that's the reason why. So now, and again, as we're starting to move into this thing of biomarker testing for treatment, that biomarker testing will actually show us trends in people that were smokers and non-smokers, and start to say, oh, well, if this person has this genetic change that we saw in the testing, maybe there is something genetic related, and we can look deeper into the family history. So this is medicine, this is developing. For the longest time, there was not a focus on lung cancer, right? Because tobacco companies didn't want you to focus on it. Now that that's gone and that's changing, we're finding out more. And I'm going to say it again, we need to make sure we find out more for our community.
While you're coming up to ask your question, Brother Watson, would you come in? Because I want you to address, being a former healthcare executive, you're going to have to address this, where insurance companies come in the role as far as covering these costs. Yes, ma'am, please.
Yes, sir. Chastity Jackson. I also wanted to, one of the questions I wanted to ask about family history, which my grandmother and my aunt, my mom's sister, passed of lung cancer. But I'm coming as an educator. I see a lot of the kids and they're vaping. We're having a lot of kids that are getting expelled and getting suspended because they're vaping in the restroom. I have family members also that nieces and nephews that are vaping, and they're being sluggish. They can't walk from to the corner because they're out of breath. What would be the earliest they could, if they wanted to get screened? What's the earliest you can, age-wise, to be screened?
So they wouldn't be able to get screened specifically for like that. So vaping is one of the things it's still developing in terms of our knowledge medical-wise. We do know the chemicals in there are a little bit different. They get a very advanced lung disease that inflames the lungs and it scars down. They get some brain, mental slowing, fog that comes around there. We know that one session of vaping, which they may go through one of the little canisters or something like that. Yeah, it's about a pack of cigarettes there. That's about 20 cigarettes in one session. And then it's flavored, so you get enough nicotine to get you really hooked in on it.
A lot of poison and stuff.
Yes. And then you get then you get the flavor so it doesn't taste really that bad. And then they know that eventually it's going to be too expensive and that it'll actually lead into them actually smoking actual cigarettes and cheaper in there. And then you see the tobacco companies are flavoring their cigarettes. This is well thought out from what they're doing. Yeah, they won't be a candidate for screening, and that probably won't come until we start to see a really high incidence of lung cancer developing in younger people as a relationship, which it hasn't been out long enough for us to determine that. But we do know that there's, and I'm glad you're an educator and you're seeing this, and we need to just get it out that that's not even good. A lot of people say, oh, I'm going to use e-cigarettes to help me quit. It doesn't help you quit. Actually, what it does is because you get such a high volume of nicotine, it's so addictive and easy to do, and you think it's socially acceptable now that you use it more. And then it becomes too expensive, so I just buy cigarettes. And that's it.
Thank you.
Reverend Dr. Watson, would you please comment? Again, we oftentimes make the health insurance companies out to be the villain. Sometimes they deserve it. But could you kind of give us a view into the perspective from the insurance providers as far as what's going on, or even from the healthcare companies?
Okay, I'm gonna put on two hats. I'm a former executive with Tenet Healthcare. I stayed with Tenet around the country for about 15 years. I'm also a former state legislator, and I was a legislator for the state of Georgia for 10 years. So most of the people came up to talk about why was it not covered. It's not covered because it's not mandated by your state legislature to cover it. So your state senators and your legislators are not saying to these insurance companies that we don't cover these screenings. So if you go to your doctor and you want this particular screening and it's not covered, it comes out of your pocket. And you can pay cash for that particular screening. The insurance companies are trying to save money. The way they save money, they say it was pre-existing or it's not covered. So when they take their EOB, which is a bill, and they show on that EOB, this is what the insurance is going to pay, and this is what you're going to pay, and you look at this test that was not covered, it comes under your pocketbook. So then you have to pay the physician or the insurance company for that particular test. How do we eradicate that? Well, with HEAL and what we've been trying to do around the country is to work with our African-American community, with our churches, and our policymakers. The only people in America that can make laws are elected officials. That's just the way it goes. So elected official, when he or she is in the General Assembly in Georgia, in Tennessee, or the state of Texas, there are two main words that scares the death out of insurance companies. And that is shall or may. And I use it in a sentence. This cover for biomarketing testing or chronic kidney disease shall be covered by Blue Cross Blue Shield and Cigna. It's over with. It's paying for it. The other word is may. It may be covered. So now they got discretionary with the doctors and the people that's coding the medical procedure, whether they want to cover it and pay for it. What is my point? The point is that in African-American communities, we have to hold our elected officials accountable for our health care in the environment, in our bodies, and in our communities. How do you do that? You do it by the vote. You bring it up by having issues and informative seminars like we're having today and panel discussions to make sure that the Blue Cross, the major insurance carriers around the country are held to the fire to make sure that these screenings that these doctors, physicians want to give to you, how can I say it without embarrassing them? They have to get paid too. So if they can't get paid for these particular services and embellish their business so they can feed their family, guess what do they do? Now, they may have the compassion to give you the test, but if they're not going to get paid for the test, then what do? So then we lose out on the benefits of taking care of a disease that can be eradicated by information, by critical care objectives and clinical trials in our communities. I hate to say that, but I put on my other hat.
Thank you very much, sir. I appreciate that. That was very well needed. And we'll be sending you the bill, by the way. Yes, ma'am.
Dolores Jackson. My question is about biomarker testing. Is that prevalent now in terms of standard of care? And when you have that type of testing done, is it just for a specific type of illness, or is it generic? Like, do you get a list of things that they can identify the propensity for?
So we've known biomarker testing is very similar to what they've been doing for breast cancer for the longest period of time. You know, they took for markers whether you're hormone receptive or not hormone receptive, and then they expand and they found a few more things and a few more things, and went to colon cancer, went to prostate cancer, and now it's across the board. We know that testing for biomarkers, because there's new therapies that you can target different cancers with off of the results you get from the testing, it has become a recommended standard of care. The thing is, it's new in medicine, and so are these therapies, and they cost money, right? And so now what the push is, if you ask an insurance company, do you want to go, you know, with biomarker testing, do you want to cover the biomarker testing? There's going to be pushback, because then they know it's going to be a new therapy, and then that new therapy is going to cost money. But it saves lives. And so there are bills. There's a bill going to be signed. It's already signed in Tennessee. I've heard Tennessee's ahead of us. Kentucky, sorry.
Please.
Sorry. Same difference. Kentucky is ahead of us, and they've already signed it, and they were one of the first ones in the nation to do so. Georgia, it's coming up to be signed here soon, and I think it's been pushed forward here in Texas, but I don't know if it's reached the point to being signed.
House Bill 989. So again, what you hear, a recurring theme here is political involvement. If we want to talk about doing some of these changes, we have to get state legislatures, not to mention at the federal level, involved. Did you want to add something else?
Yeah, that was
Yes,
a recommendation about testing and my family for leukemia. But my insurance company would approve the generic scan, whole body scan, to determine if it's any tumors, anything's going wrong, but was not really receptive to the test that would determine any of those types of propensities for those type of illnesses.
Let me ask Dr. Green something. Because you alluded to it in your, and thank you very much. You alluded to it in your presentation, Dr. Lowe, but Dr. Green, we are chasing our tails when we talk about doing screening to find a disease that is asymptomatic, and yet we can do something to help a person. And then we're trying to talk about all these wonderful treatments. Tell me about trying to get people to stop smoking. What are the things that you have found that have been of benefit in your practice?
Well, we have to use what we call the scare tactic. You know, you have to put in, you know, you have to show people, you know, not only they, you know, looking risk of emphysema and COPD and, of course, lung cancer. You know, I show them pictures of people in wheelchairs with amputations. Because a lot of people don't realize, you know, because smoking is one of the biggest causes of peripheral vascular disease, okay? Kind of combine that with hypertension, high cholesterol, and diabetes, you know, within a couple of years, you know, you're looking at an amputation. Once you get that diabetic sore, that foot ulcer that you can't cure because you continue to smoke, poor blood circulation, the wound won't heal, it gets down to the bone, and next thing you know, you're having the amputation done. So I showed them pictures of that, okay? And of course, I actually, you know, push on them that there are options out there, you know, and of course, there are therapies for smoking cessation, okay? And I don't want to mention any of them, you know, for lack of, you know, I don't know how it is the marketing situation, but there are ways out there to stop smoking.
And then there's support and quick groups. And we work with, especially in the Atlanta area, we work with a lot of the churches to help support that, because that's one of the communities that can really come together and help. And the other thing that we need to really realize that makes it hard for people to even come forward is that sense of shame, right? Because people start shaming and blaming themselves about smoking or the concerns of cancer. And that really sort of holds them back. We don't want to hide things back or pull things back. And the thing is, if you know that you smoke, you know at risk for screening, it's to go forward without blaming people, without shaming them, but actually helping them get through this. And I mean, support groups, 1-800-QUIT, quit smoking, you know, helplines. There's a lot of different areas and avenues that'll help support people through this process.
We'll have one last question. Yes, ma'am, please.
Okay, these are the questions that are online. They say they text.
Take the top one.
The first one is from Shonda Broussard. She said, when should a non-smoker who has been exposed get screened?
And let me just say that some of the other questions that you have, if you'll give them to me, during the course of the rest of the event, we will get to those questions. So the question is, we've already addressed that one. Give me another one if you could.
Okay, the other one was,
And the answer, by the way, for when should a non-smoker get screened, right now there's no criteria for screening for that individual. If they want to do the testing, they're going to have to pick up the cost themselves.
this should say, how can we better explain the negative effects of cigar smoking versus cigarette smoking? Most people think it's better to smoke cigars rather than cigarettes because the risks are lower.
Dr. Flynn, one of you, just briefly, because that was
See, one thing about cigars is like, with alcohol use, more like it's a social situation. Some people do not smoke cigars every day, as opposed to people who smoke cigarettes every day because you're in a social situation. You at a party, you at a bar, you at a gathering, and of course the cigars come out. I don't smoke cigars, but I have a lot of friends, a lot of fraternity brothers who do. And we have a gathering, next thing you know, cigars out. And what's unique to me now is the number of women that are smoking cigars.
Well, oh, yes, sir, go right ahead.
So, yeah.
You're a cigar smoker, is that what it is?
So, cigars, smoking, it's, you're looking about one cigar is about 16 to 20 cigarettes in one sitting, right? So that's one thing. A lot of times they're unfiltered, right? And so now the deposit of whatever the carcinogen, the cancer-causing substances are not getting, deeper into the lungs. So it's not only going into the lungs, it's depositing, so you get oral cancers, you get throat cancers, you get nasal cancers a little bit more prevalent in prominent cigar smokers. So
Pastor Jefferson, I just have a question. When one leaves the house of the Lord here, you carry that with you when we go home, right? Do we allow smoking in the church here? Then why would we do it at home? So that's one thing. Thank you all both very much. That was kind of interesting. Unfortunately, Kentucky Derby's coming up, and the big passion there is bourbon and cigars. Please don't tell me not bourbon too. We're going to take a slight change in how we're going to look at things right now. We're going to have, I'll just say it, Ms. Roxy Hall Williamson. She's going to talk a little bit about lung cancer survivors, caregivers, and how to go about handling the diagnosis and getting support and resources. Ms. Hall Williamson, you want to stand there? Would you like to stand here, or you want to sit down? Yes, you may sit down.
Oh, there you go. Hello, everyone. Hello. How y'all doing? I'm going to start out like I start out every morning at home. Good morning, saints. God is good. I don't really know where to begin, so we'll just start from how I even found out I have lung cancer. I'm Roxy Hall Williamson. I live in Galveston. I am a pretty busybody. I love all the legislative talk, so I hope that you guys that's resonating, because as a grassroots organizer, I need you guys. I need you to talk to your congregations, your families, your friends, and let them know that voting is great, voting is good, it's cute, it's fun, but we need people really dedicated to making change, to go beyond just voting. We need you guys to become voter registrars. We need you to get with your precinct chairs. We really need some soldiers on the ground right now to help when it comes to when this legislation hits the floor of the Senate. The most effective testimonies come from the community. The most important input comes from the community, whether you write it and send it in, or if you can show up in person, or if you can just go talk to your folks in your district to let them know that these things are important. We need this. We need this legislation. I am one of the Texas millions that's uninsured. So my diagnosis came with the whole extra burden of how is this going to be paid for? Am I going to live or am I going to die because I can't afford to be in UTMB right now? So my story begins, I've been having symptoms for a long time. Of course, hindsight is 20/20, right? I've been going through some things, but as a black woman, it was chalked up to, oh, you're getting to that age of menopause, everything was menopause. Everything was blamed on menopause. And ironically, I began to really have some really terrible, terrible headaches. I was never a headache person. I never suffered from headaches. So it was concerning, but not enough for me to slow down to go get checked out. And finally, Uvalde happened last year on the 24th of May, which was exactly 7 days from my 53rd birthday. My birthday is very important to me, and that was the first year in all the years I've been alive that I could not celebrate because I was in so much pain. I was hoping to go down to Uvalde to help some of my grassroots folks down there to, get on the ground and help those families. I was in so much pain. I did an emergency U-turn in the middle of the seawall and took myself to the hospital that evening. I want to say they whisked me in. It's probably about 7 or 8 o'clock that evening on the 24th. By lunchtime on the 25th, Dr. Patterson was explaining to me why an emergency brain surgery was at hand. As all things, I leaned into my faith and I said, God, handle it. Take the wheel. I'm here. Dr. Patterson, do what you have to do. If I come out on the other side, we'll talk about it. I'm on the other side. We're talking about it. What was I think the heaviest thing for me once we had the brain surgery done, we still didn't know that I had lung cancer. It was just, you have some masses on your brain, we're gonna take care of that, and we'll figure it out. Well, a couple weeks later, the pathology comes back, it's stage 4 lung cancer. It's non-small cell, which I think qualified me for the medication I'm on currently, but I'm skipping ahead a little bit. So I received the diagnosis, and the term cancer didn't floor me. It was that my treatments would be palliative versus curative, meaning I'm beyond the stage, according to the doctors, to be cured, but I will be given the kinds of therapies that will help my quality of life, hopefully sustain it for a little while longer than maybe it would have previously, whatever, how that works. This morning is a perfect day in the life. I was supposed to be here early. I was actually supposed to be your moderator today. But as some of the side effects from the Tagrisso medication that I am on, I could plan a really good week in the morning of my stomach isn't so nice, or I just can't, my body won't do what my brain is telling it to do. Currently, I know you can't see it from back there, but my thumb is splitting. It looks like I cut it. That's one of the side effects from the medication as well. You get the cracked skin and the dry skin. It's not a lot you can do about it except just stay moisturized. And one of the other patients, when I attended the Lung Cancer Summit in DC a couple of months ago, suggested I get what they call finger cots that protect your fingers. It's like a little silicone kind of like Band-Aid for your fingers. And you can still use your technology. So I'm going to tell you guys, if you know anybody that's on any medication that are going through these kinds of things, I found that these stylus pens with the tip on them so you can use your phones, because it hurts even to tap the keys on my phone sometimes. So I guess I kind of skipped around a little bit, but I think the thing that I would want to tell everybody listening right now is any legislation that's coming up for early detection, please support that. I know that God is real in my life, so I don't take this as, oh, I have lung cancer. I take this as an opportunity to further my advocacy work. It's personal. And though I have cancer in my family history, I believe I'm the only one with lung cancer. So that was very interesting. And yes, I'm a recovered smoker. I wasn't really a cigarette girl, but I am a part of that freaknik culture. I will tell on myself, but I wasn't doing anything bad past them. I was out there just having a good time, and marijuana wrapped in the cigar paper was my thing. So full disclosure on that part of it. But my doctors were very loving, and I was very honest with them about my smoking history. And my doctor, Dr. Kramer Smotherman, told me pretty much, you know, these things present themselves in different ways. There's no reason for you to feel any shame for that. This is, you know, part of the journey. And my team at UTMB, and I'm fortunate to live in Galveston, right around the corner from UTMB, those doctors it's a really nice mix with the students and the doctors from MD Anderson. So the team has been just very loving and caring. And there are programs for folk that are uninsured that they have in-house that have been helping with my scans and my treatments. And they haven't cut all of the indigent care out of Galveston County yet. So that has been helpful to me as well. Otherwise, it's been my church affiliation. My mother is a retired nurse and a member of the Gulf Coast Galveston County Black Nurses Association. So I have a lot of sweet aunties that are always looking out. And it's just me by myself. My daughter's an adult. She lives in Georgia. So food, all those basic things to live haven't necessarily been a strain because I'm the only adult child at home right now, so I'm being pretty spoiled. My parents cook a lot, and they love on me, and that's another thing that I think that people overlook. The caregivers, your family and friends that support or don't support, right? That's a big deal in your journey to healing and recovery. And I don't know what God has planned for me other than I'm here. I'm in these legislative streets. I'm doing my best to inspire and educate and invigorate those around me to be a part of the process. Be a part of the process because you're the answer. The electeds really can only do so much, but with the community behind them, with the community being involved, with the community being seen and heard, those are the things that make the difference with this legislation. And we live here in Texas. Y'all know what it is. I don't have to. Y'all know what it is. From diversity and inclusion to who is covered by health care. These things are so important. And I don't mean to beat that horse to death, but I just can't emphasize enough how bad we need the community to get involved in this legislative process.
May I ask you?
Yes, sir.
And thank you for sharing this story. It's really interesting. Thank you. But there are a couple of points, if we could, if you don't mind us asking you.
Yes.
Because you're it, so that's great. And you're such. By the way, you all can't quite see how fashionable it is because the earrings and this bracelet, they're just kicking it. I want you to know. But anyway, that's another story. As a longtime smoker, how effective are the deterrents that we're putting out there right now? Some of the commercials, we've all seen them, where the woman who is, you know, got the tracheostomy, the guy who, woman takes off the jaw. I mean, as you think back from your smoking and you talk to your peers, is any of that any good, or are we going about it totally wrong?
Full disclosure, it's totally wrong. Totally wrong. Part of the reason I agree with the doctor earlier, the shaming, you should, doesn't work. And when those commercials elicit certain images in my mind immediately, it's not culturally relevant. So it's very easy to turn away and say, well, that's them folk. That doesn't apply to me. That doesn't look like me. you have to have representation that looks like the audience you're trying to target. And you have to not be afraid to step into the space and say, hey, bruh, sis, I know it's fun. I know you think those blunts are the thing, but you can't do that. And most of the target audience aren't smoking packs of cigarettes a day. They're smoking cigarillos. They're smoking weed. And when you see, if you know anything about the marijuana culture, you have certain people making billions off of it and other people being criminalized for it. So until we can really have an honest conversation about the marijuana culture and the different advantages that cannabis offers that healing space, you can more effectively get people to transition from smoking to maybe ingesting the good parts of it in different forms. But the way it's going about right now, no, you're offending the folk that you need to reach.
Would you expound upon something? We're going to later on have a panel talking about navigating things, but you clearly are a force of nature for yourself. How does one go about trying to navigate this very, very complex healthcare system, especially when you're thrown into the deep water with a diagnosis like you had? Do you have to be your own advocate, or are there resources that are out there, and how do you access those?
This is an amazing question because I have not figured it out. I'm still in the process of working through that. From what I can tell you is, number one, I will emphasize family and friends networks, because without my mom and my squad, I don't know how far I would be in the process right now. Because first of all, lung cancer, like where I'm from in my region, you have breast cancer stuff everywhere. There's always a walk, there's always a talk, there's always something about breast cancer. But when it comes to the other cancers that I've been looking into lately, there's really not a lot for us. And that's my mission for myself right now, is to connect more lung cancer patients and see if we can somehow bridge those gaps. But for right now, I have a breast cancer friend online that is always sending me resources because she's been in her struggle for a long time. So she has resource after resource that she shares with me. Some of it works for me, some of it doesn't. Myself, and to answer that question, yes, you're going to have to be your self-advocate. You're going to have to speak up for yourself. You're going to have to ask the questions. And you might get pushback. I've had to handle a couple of nurses, like seriously handle them as professionally as I could, but letting them know that I'm not the one. You're not going to leave me sitting in a waiting room by myself and turn out the lights and forget that I'm here. You're not going to do that again, right? So you have to be able to speak up for yourself. And if not you, if you're still too timid for that, you're going to have to get somebody on your team that is not going to be afraid to talk to your medical staff and have the conversations with the pharmaceutical company if your shipment gets missent, which happened to me over the Christmas holidays. So there are a lot of things to navigate. And as I'm working on figuring out who those people are that I can use as resources, I think it's important to have these sorts of panels in order for, because there might be somebody out here that knows somebody that could connect them with me, and we could build a network. And I'm still working on that.
You clearly are the one with the disease. The patient has it, they know it, they feel it, and they go through the stress and strains. But as you mentioned, you have a support service. What is the impact of your disease on your caregivers? Because as much of a strain as it must be for you, there is both the psychological and, quite honestly, financial burden that they must bear. Tell us a little bit how that goes.
It's difficult, and I can't speak for anyone but myself right now, but I can give you what I think is going on. Because my mother is my primary caregiver. And in the beginning, of course, leaving the hospital with emergency brain surgery, I had to live with my parents those first, I would say these first 6 months of the diagnosis. And it was very hard on her. And not that she said anything to me, it's just I know my mama, right? You know your loved ones. And I could see the moments that she would probably want to go in a closet and cry. I could see her face when the doctor gave the diagnosis and, you know, when he announced that, okay, we're gonna have to do this surgery. Financially, again, it just depends on your circle. For me, shouting out my beautiful, wonderful sorority sisters with Alpha Kappa Alpha Sorority Incorporated, Beta Phi Omega chapter in Galveston.
No commercials, no commercials.
But when it came to finances, because I had absolutely nothing, and my sorority sisters came through with gift cards. My group that I do a lot of my community work with came through with meals and those types of things, those first few weeks I was home. So I know that took a big burden off of my parents when it came to, you know, how do we navigate this, with her here. And they're both on fixed incomes. So, you know, those things were very important to have. People at the church that didn't mind, you know, that would bring a casserole, you know, once or twice a week. It really did make the difference because my mom, is amazing, but like she tells us all the time, she's only cooking this many times this week. So you gotta get your business together. And it's been a lot to navigate. So I can't imagine what a patient going through this, how they're handling it if they don't have those resources in place, right? And I know for a fact that we have patients that don't have those resources. So we've got to somehow find a way in community to plug those gaps for people. And it's not always your elderly. I'm 53. Pray God I'll be 54 in a few weeks. And according to the folk I've talked to, that's relatively young to kind of be as far into the process as I am. So I can only imagine. And from what I've learned, the diagnoses are getting younger. And it would just be important for us to plug these gaps where we can now, so the folk coming behind us will at least have something to build from.
You did mention about your own advocacy about not, I think you used the term, so that the nurses didn't turn the lights off when you sit in the hallway.
Well, it happened once.
Well, and to that point, I think those folks in healthcare, those present, not included, of course, sometimes we forget that though we may have seen this before, this is new to you. So what is the advice that you would, number one, give to the docs and nurses? And number two, what is it that you tell other patients to say? Make sure when you're talking to your providers, these are the things you need to come to grips with.
That's a thoughtful question. I would say to the healthcare providers, don't make assumptions. Don't assume that by however the patient is looking to you, that they have access or don't have access. If you have resources, share them, but don't assume everybody knows how to navigate the internet. Don't assume that everybody can afford to drive somewhere outside of their community. I live on Galveston Island. It's an island. If I didn't have a car, there's a lot of things, like today would not have been possible, right? I wouldn't have been able to get here. We don't have any comprehensive transportation services that are inexpensive enough for people to be able to get off the island to come to a support group or that kind of thing. And I would say to potential patients, don't make assumptions. Don't assume your healthcare provider knows your life, because they don't. If you can't afford something, or if you can get somewhere, be sure that somebody knows that, because there may be resources for you, but they don't know that you need them, right? Closed mouth don't get fed. That's what I would tell them, because a lot of times we assume that as patients, you know, that you can kind of look at me and tell, you know, that I'm this or that or the other, and you can't. And you wouldn't want anyone making those kinds of assumptions about you, right? So I just try to be as clear as I can be, as vocal as I can be, and when I need things, I ask. And a lot of people don't want to ask. They feel some kind of way about making the request. And luckily, I have the kind of mother that was never that type. You didn't point for her. You didn't, You had to speak what you wanted. You had to say out loud what you needed, or you would be sitting in your own stew trying to figure it out. So
That's an interesting point, because I think sometimes we want to help somebody, such as yourself. But sometimes we say, well, I don't want to offend. May I say Roxy?
Yeah.
Is that okay?
Yeah.
Thank
yeah.
you. I don't want to offend Roxy by just showing up and dropping a casserole or steak and potatoes with a nice salad, Caesar salad if you want to bring me something. But, you know, we say, I don't want to infringe on her. Should we infringe? And tell me how that goes.
First of all, yes, you should infringe, but don't just pop up with a casserole. Make a text, send an email, and say, sis, what do you need? And I will say, I'm good on food today, but I need help with my light bill. Or, you know, hey, I have this gift card for some groceries. Could you use that? Yes, I can use that, and I can also use a gas card, right? Just opening up the door and just being direct about it. And I know, like I said earlier, I know a lot of patients. I know coming from my standpoint, I'm very independent. And going back to the question about the impact, right? When I made up my mind that I could drive without fear of having seizures and I could get back to living on my own, I was expeditious about getting back into my own place. And in the beginning, my mother was not okay. She was not okay. She said she was, but she was not okay. It took my aunt and my sister to talk to her and make her understand that because my treatments are palliative versus curative, wouldn't it be better to let me live as independently as I can while I can? So if I do get to a point that I needed to go back to them, that I have done my thing, and now I'm, you know, that kind of transition would be a little easier, as opposed to just feeling like I couldn't live my best free life because it would offend my parents. So she had to come around to it, and when I finally was approved for my apartment, and thank God for the state of Texas and the Texas Homeless Network that worked out my housing for me, she had to talk with me. She sat me down and she had to talk. She said, you know what? They had to talk to me, but I understand how important it is for you to live your own life right now. But if you need mama, mama is here.
Are people afraid to be around you sometimes? And you know, there's one of the things where we talk about how one does get, and Dr. Flano did not mention this because it doesn't happen, but they may catch it, or they're just afraid of being around you for whatever reason. Do you find that, and how do you know?
I think I have a couple of cousins that are because of the smoking thing, because they're still doing their thing, and they're like, you know, they don't want to feel, maybe they think I might preach at them or something, but I wouldn't. And those are things that they have to navigate for themselves, like I had to navigate through mine for myself. So, but otherwise, no, not so much. I'm normally in a space that I'm advocating for something else, so I'm normally with my tribe anyway. So.
Let me ask one last question. You talked about it several times. You talked about the importance of getting legislation. Are you one of those who says get out and get the vote?
I am. I am the founder of Galveston Island Voter Education Resource and Services, Givers, Texas. And that is my whole joy and work with the rest of my life right now. Like I said, voting is great, but there's so much more to the process than just casting a vote and casting an intelligent vote, right? So I'm trying to get us back to those Schoolhouse Rocks days where we know, you know what I'm saying,
Yes,
where we
ma'am.
could recite it. I'm just a bill. I'm only a bill. But there's so much more, especially here in Texas, to the legislative process that I find that a lot of us just don't know. And it's past time that we learn and pass things. I want folks to pass the desire to vote along like generational wealth, right? It's just ingrained in what we do.
It's amazing how healthcare can lead you along so many different journeys, isn't it?
Yes, it
Roxy,
is.
I want to thank you very much and applaud you. That's a tremendous, tremendous story. And
I
am
hope it was helpful. I just hope it was helpful.
It's going to be quite helpful.
Thank y'all for listening.
Thank you again. I'd like to remind everyone, if you would again, please be sure and fill out the survey and turn it in for those of the folks here and, of course, online. I know everyone's already done that. We're going to take a short break as far as lunch is concerned. Roxy, you were the last thing between us and lunch, but I've never saw more people more attentive to somebody before lunch in my life. So you did a great, great job. So again, we're going to have lunch. I think it's going to be, yes, ma'am. You had a question.
You have a question and answer period? I'm looking at the sheet.
I'm sorry, I did not recognize you for that. We will come back to that after, because we've now time for our break. Again, if you'll have those questions for us, we will get to those for the next session and have those questions and answers then. We'll take a break as far as lunch is concerned, and we
And we are back with more What's Now, taking our attention to health and wellness, especially lung cancer. I recently spoke with two individuals who have had lung cancer and very different experiences and journeys, and they have some great insight. Let's take a look.
You've been diagnosed with lung cancer. So what now? What do you need to ask? Where can you go? And how can you find the newest treatment options? Unfortunately, lung cancer is a leading cause of death among Black Americans. And here to talk more about this is Dr. Sydney Barnes and Brandy Bryant, both lung cancer survivors. Thank you both for being here today.
Thank you for having us.
Thank you.
Dr. Barnes, let's start with you. You are a lung cancer patient and a doctor. Tell us about your story.
I noticed when I started residency that my exercise tolerance was diminishing. I was becoming more short of breath. I am normally a very active person. I dance, swim, run track.
And we are back with more What's Now, taking our attention to health and wellness, especially lung cancer. I recently spoke with two individuals who have had lung cancer and very different experiences. And we are back with more What's Now, taking our attention to health and wellness, especially lung cancer. I recently spoke with two individuals who have had lung cancer and very different experiences and journeys, and they have some great insight. Let's take a look.
You've been diagnosed with lung cancer, so what now? What do you need to ask? Where can you go? And how can you find the newest treatment options? Unfortunately, lung cancer is a leading cause of death among Black Americans. And here to talk more about this is Dr. Sydney Barnes and Brandy Bryant, both lung cancer survivors. Thank you both for being here today.
Thank you for having us.
Thank you.
Dr. Barnes, let's start with you. You are a lung cancer patient and a doctor. Tell us about your story.
I noticed when I started residency that my exercise tolerance was diminishing. I was becoming more short of breath. I am normally a very active person. I dance, swim, run track, and I realized that I was just getting more and more short of breath, and then I started wheezing. Now, I do have a very strong family history of asthma, so I thought that was what was going on, but I decided to go to a pulmonologist to get checked out. And after a whirlwind of tests, actually got diagnosed with stage 4 lung cancer, which was completely shocking to me because I have no risk factors for lung cancer. Thankfully, they sent my tumor off for biomarkers, and I was found to have a biomarker, so started on targeted therapy, and I was able to complete my residency working 80-hour weeks and continue working and living a very normal life. And now I'm no evidence of disease 5 years after the fact, which is amazing.
That is amazing. Brandy, you're also a lung cancer patient, and you're doing very well on targeted therapy because you found out about your biomarker. Tell us about that.
So my story is similar to Dr. Barnett's. I was 39 years old, very busy mom of 4. I had a tiny cough for months that I didn't think anything of. It was really quite minor. But and I was active. I like to take long walks, walking like 25 miles a week. But after the walks, I noticed shortness of breath when I was just having conversations. So that prompted me to go to the doctor. After a series of tests, I was diagnosed with stage 3B lung cancer. I was initially diagnosed at a local community hospital, but I was very fortunate that they did send my tumor off for biomarker testing. I had no idea what that meant. And I still had to, because I was stage 3 when I was initially diagnosed, I had to do chemo and radiation. However, when I progressed a few months or just 2 months later, I had the choice of doing immunotherapy or targeted therapy. But because I knew what my biomarker was, ALK positive, I knew to choose targeted therapy because immunotherapy doesn't work well for ALK and a lot of biomarker driven cancers. But it's definitely made things much better for me. I had my youngest kid was 3. I couldn't climb the stairs. I couldn't do anything. And once I started taking the targeted therapy, I felt markedly better within just a couple of weeks. Like the fluid was draining from my heart. Everything was feeling better. And I've been no evidence of disease since 2018.
Dr. Barnett, tell us exactly what a biomarker is and why patients need to ask their doctors about them.
So each cancer is unique, and some cancers have mutations that are driving the cancer to progress. And that is what the biomarker is. A biomarker is a mutation that is driving this cancer. There are many different biomarkers such as EGFR, KRAS, ROS1. Brandy and I are both ALK positive, so our mutation is ALK. And what a targeted therapy is, it literally zooms in on that mutation and turns the mutation off. It's so much better tolerated than chemotherapy and radiation therapy. It actually works much better for these mutations than the chemotherapy. And because of that, a lot of patients are able to lead pretty normal lives with it, which I think is one of the reasons why research is just so important. had we been diagnosed 10, 15 years ago, we wouldn't be here. And now we need to know what further therapies are out there and what reasons people are getting cancer so that we can potentially save more lives.
Brandy, would it have made a difference in your treatment and in your quality of life if you had known your biomarker earlier?
I was fortunate to know my biomarker earlier. I just did not qualify for the treatment at the stage. At that time, I didn't qualify for the treatment at the stage that I was initially diagnosed, but it definitely made a difference whenever I progressed to stage 4. Knowing that I had that biomarker gave me a treatment that actually saved my life, because immunotherapy does not work. It actually it has the opposite effect on ALK positive and some other biomarker driven cancers. So without that, I wouldn't be here today. So biomarker testing was extremely important and is if you're newly diagnosed.
And Dr. Barnett, how can people be screened for lung cancer and who should be screened?
So right now, the screening criteria is geared towards smokers. If they smoke 1 pack of cigarettes a day for more than 20 years, if they are between the ages of 50 and 80, if they stopped smoking, less than 15 years ago, they do qualify for a low-dose CT for screening for lung cancer. However, I do implore anyone who has a persistent cough that won't go away, anyone who's wheezing without any history of asthma, anyone who has been treated for pneumonia more than once and the symptoms is not going away, I would implore them to speak to their doctor about getting screened for lung cancer, because these are some of the symptoms that a lot of lung cancer patients who have no known risk factors are presenting with. And the earlier that we find the lung cancer, the better it is.
Brandy, when you learned about lung cancer, were you surprised about how little federal funding is earmarked for lung cancer?
I was very shocked to learn about that as I got into lung cancer advocacy, because for me, the drug that I started taking, the targeted therapy, just came on the market 2 months prior. And that's due to research. And if we don't have the research funding, then we can't get these drugs to help people with this #1 cancer killer. I want to be here for many, many years with my children and my family. You want to be with the ones that you love. We want to be here, and we want to help newly diagnosed people have hope. And you have hope when you see people like us, right? So the more research funding we can get, the more that we can get these therapies and treatments that'll help us be here longer.
And Dr. Barnett, tell us more about why someone who has lung cancer would join a clinical trial and how people can participate.
So one of the things I want patients to know is clinical trials are safe, and clinical trials are the way that we learn the therapies of tomorrow today. It tells us how we can learn more about the cancer, what is driving the cancer, and research is what gave us where we are right now. And if the traditional therapies are not working anymore, if chemotherapy, radiation, immunotherapy, targeted therapy are no longer working, then it is so much better for you to go into a clinical trial to find out what can prevent your progression, further progression from happening. Now, if my cancer was to come back and was not responsive to things that were on the market, I would definitely go into a clinical trial. And that is one of the things that I want people to know. Clinical trials are definitely the way moving forward if you are not able to do any other therapy.
And Brandy, any other advice for our viewers, and where can we find more information?
So yes, the advice I'd like to give is if you're newly diagnosed, please ask your doctor what is your biomarker. And if you want more information, you can visit lcfamerica.org, where there is information on the different types of biomarkers, treatments, clinical trials, and more research, which is critical. So lcfamerica.org.
Well, thank you so much, Brandy Bryant and Dr. Sydney Barnett, for joining us today. Really appreciate your time and how thoughtful you've presented this information and shared your story.
Thank you.
Thank you.
Welcome to Chronic Love, a supportive space for people with chronic illness. I'm Robin, a psychologist in New York City, navigating the fallout of a breast cancer diagnosis some years in. And I'm on a personal journey to join together with others who have similarly found themselves facing life challenges in the wake of chronic illness. Together, with the generous humans you're about to meet, we welcome you into our discussions.
I just remember feeling like, what the hell did I do? You know, like, how is it that, how?
Yeah.
You know, like I didn't even smoke. I never did hard drugs. I really lived a straight and narrow life. So I'm like, I don't understand what I did and why all of a sudden now this is my story.
How did you come to understand your illness, the severity of your illness? Is it okay if we talk a little bit about that?
The only way for me to really talk about that is to kind of go back to the beginning. Because my diagnosis was, the whole procedure was crazy. And so if you don't mind, I'll start at the beginning of how I got diagnosed and answer your question along the way, if that's okay.
Is that okay?
That's perfect. Yeah. In April of 2018, I developed this wheeze that really was, you know, not really that bad. It was something that only popped up when I would go to sleep at night. I would lay down to go to bed and, you know, I would just have this little like wheezy cough or whatever, and it would go away, you know, and then I would fall asleep and everything was fine. It then expanded into something that happened more regularly. So then it started happening when I wasn't going to sleep. It started happening when I was getting off the subway. Mind you, all this is taking place in New York. I was diagnosed in New York. But it started happening on the subway. It would happen when I went into work. It would happen when I was sitting at my desk, when I was at home. And it became a thing where I was trying to pinpoint, maybe it's something in the atmosphere, maybe it's like allergies, maybe it's the HVAC system. I'm trying to figure out all these different reasons why this wheeze has now started to follow me around. And then I decided, you know, I got a cold and the cold went away, but the wheeze stayed. And of course, in this day and age, we Google everything. And so I, of course, Googled, you know, what happens if your cough stays and your cold goes away? And they're like, oh, it's bronchitis. And I'm like, oh, okay, maybe I have, you know, bronchitis. And so very nonchalantly, I went to the doctor just to see what was going on. And he was like, okay, well, you know, here's a breath test. And they gave me the breathalyzer test where you like breathe into a tube and it determines what your lung capacity is. So if you have asthma or allergies or whatever. So I took that test and it came back sort of inconclusive for either of the two. And so he was like, okay, well, I'm just going to give you this inhaler. And whenever you feel like you have to wheeze, just use the inhaler and you should feel better. And he's like, come see me in 2 weeks and let me know how you're feeling. I didn't really think anything of it, of course. And so I actually used the inhaler for 2 weeks, came back to him and I was like, it's not helping. It's not really helping at all, to be honest with you. And so he was like, all right, well, I'm going to write you a script for a cough suppressant. And then he just sent me on my way. That was it. There was no x-ray. There was no further communication. It was just, you know, oh, the inhaler didn't work. Okay, well, let's get rid of your cough. And here's a medicine for that. And he just kind of let me go. At that point, I just realized like I wasn't really getting any help from him and I wasn't really getting any answers. And so I kind of just kept on living my life, you know, for a little while. I was, you know, 30 years old at this point. So in a relationship, you get that 30-year-old metabolism and comfortable relationship weight. And I was like, oh no, I got to start getting into the gym. But for me, I never really liked going to the gym and I wanted something more interactive. And so I ended up getting into kickboxing. And so I was doing a lot of high intensity cardio. And so I started to, you know, as my symptoms developed more, I started to attribute them to the high intensity workout that I was doing. You know, so the wheezing turned into a cough and some shortness of breath, which I assumed was, oh, you know, kickboxing, it's intense. You know, I'm not used to this kind of working out. And then the shortness of breath turned into, you know, some back pain. And I was making excuses for all of these symptoms that I had. But I started to know that something was really wrong. There's always that turning point where you realize like, okay, this is the thing that lets me know something is wrong. And that point for me was being in the gym with my, at the time he was my boyfriend, now he's my husband, but we were on the treadmill and, I'm not the most in shape person, but I know that I can run a mile and be okay.
Mhm.
And so I got on the treadmill and I was running right alongside him and I got to about a quarter of a mile and I was like I had to stop. I was like, I'm not breathing. And it's like, it wasn't like one of those things where, if you're a runner, you hit that runner's high and you're kind of good to go. It was like, no, I'm actually not getting enough oxygen. Like I have to stop. And I realized at that point that something was really wrong. And he was like, you need to get a second opinion. You need to go get this checked out. And I was like, all right. And so I made my second opinion appointment. And because I'm a new patient, they kick new patients out, a month or two. Like for whatever reason, doctors are always a month or two booked. And so I didn't get my appointment until about December. So remember, all of this started in April.
Yeah.
And so December came around and I went to my appointment and I told him what was going on and what was happening. And he was like, well, have you had an x-ray? And I was like, no, nobody's giving me a chest x-ray at all. And he was like, okay, well, go upstairs and get a chest x-ray. And he's like, and when you come back downstairs, we can talk about the results. And I was like, okay. He was kind of shocked. He's like, why have you not had an x-ray? And I'm like, no doctor has sent me to get an x-ray. I just was like, no, I just never had one. So I went upstairs, I got the x-ray, I came back downstairs, and I'll never forget the look on his face. It was like all the blood had drained from his face and he was like pale. He's like, are you feeling okay? And I was like, I mean, yeah. It's like, I'm tired, but I'm always tired. So I was like, but I feel fine. And he's like, your entire left lung is covered in fluid. And I was just like, what? And he showed me the x-ray and I couldn't believe it. I was just shocked. I was like, I don't understand how this is even possible. And he's like, well, I need to admit you to the hospital like right now. And I was like, whoa, okay, wait, hold on a sec, time out, pause, wait. I was like, I was not expecting, I'm not ready to get admitted into the hospital. I had a whole bunch of stuff going on. I was just like, whatever this is, it's got to wait another 3 days. It's just got to make it through the weekend. And so he was like, well, in the meantime, let me send you for a CT scan so we can see if this is fluid or if it's, a mass. So I went in and got the CT scan done. And then I kind of went on about my business all through the weekend. I went to work on Sunday. And I remember that day being like particularly difficult. I just was like, I really don't feel good today. My back was hurting. I was shortness of breath. I was tired. I think it was like, it's like, they call it that, like, it doesn't hurt until you look at it type situation.
Yeah.
I was perfectly fine until I got the scan. And then all of a sudden I was like, I just don't feel good now. I was like, now my body was like, we know something's wrong. And so let's start, broadcasting it. But anyway, so on Sunday, I called the doctor and I was like, what was the results of my CT scan? Like, what's the situation? They were like, you need to come in ASAP. And my best friend, my best friend Sade was like, so you're going, right? And I'm like, yeah, I'm going to go. She's like, no, you're going to go tomorrow. I'm going to come up tonight and you're going to go tomorrow, right? And I was like, yes, I'm going to go. Best friends are always like, get your behind to the hospital.
Yeah, thank goodness.
So she came up to New York and we went into the hospital and I ended up being in the hospital for 6 days. And they gave me a chest tube. It was awful. I was awake for it and I felt every bit of it. But they gave me a chest tube and they drained 2.5 liters of fluid out of my left chest capacity area. I was basically carrying around like a 2-liter bottle of soda in my chest somehow and functioning. So they drained that much fluid out. It took about 3.5 days before it was finished, and they were finally able to take me off the machine or whatever. But while I was getting the lung drains, they tested the fluid. At first, they told me I was fine. At first, they were like, yeah, the fluid tested fine. There was no malignancy. You're good to go. Like, we're just going to drain this and you'll be fine. And I was like, oh, okay, great. Phew. Like, thank goodness. Then they came back and they were like, no, actually, your fluid is testing positive for malignancy. And I was like, well, malignancy is cancer, isn't it? And they were like, yeah. And I was just like, what? Like, none of it made sense. I couldn't comprehend. People don't lie. When they say they have out-of-body experiences, it's real. Like, you really experience things from outside yourself. Like, you're watching yourself get this news and you're like, what is really happening to me right now?
Yeah.
And so when they finished doing the lung drain, the lung didn't fully inflate because the fluid had crushed my lung down into like a ball like this. And so once they pulled the fluid out, the lung was working on expanding. And so they were like, oh, there's some spots on there that we don't like. We're going to do a biopsy and test and see what's going on. And I was like, okay. But in the meantime, they were like, we're going to send you home. So I went home with this knowledge that I have something going on with me, something cancerous going on with me. I don't know what it is, and I have to wait 5 days for the biopsy test to come back. So that was December 15th or so. December 20th, I had an appointment to go sit down and see what was going on. And that was when they told me, yeah, you have cancer. It's lung cancer. But we went ahead and did genetic testing, and it's a biomarker testing, and it's out positive. You're going to take some pills. Everything's going to be fine. Totally nonchalant. I mean, we were joking in the doctor's office. He was like, you should switch to a plant-based diet. And I was like, oh man, I love my steak. And he's like, yeah, no more steaks. Like, we're just joking and having a grand old time. Like, he didn't just tell me that I have, a cancer diagnosis, but I walked out of his office thinking that I had some mild form, of cancer, and I was going to take some pills and, do some treatment and everything would be okay. And I had no idea. And so I left and, kind of went home, and honestly, I can't tell you, I don't remember what my thought process was after that. Honestly, I really just I don't recall, but I know I started getting shortness of breath a couple of days later. And so I panicked because I was like, oh no, now I'm on like terror alert orange at all times for my breathing patterns. I'm like, I'm very much aware if I'm having breathing issues.
Yeah.
And so this was right between Christmas and New Year's. And so I started having the shortness of breath again, and I wanted to see my doctor, but he was, away because it's Christmas, he's with his family.
Yeah.
So I went to my original pulmonologist, the one that did my first original chest scan, and let me know that there was something wrong. And so I went to him and I was like, hey, I got an appointment. I sat down. I was like, I'm having shortness of breath again. I just wanted you to check and do an x-ray and see if like I'm good and what's going on. And he's like, oh yeah, with stage 4 cancer, you're going to run into that a lot. And I was like, I'm sorry, what did you just say to me? And he was like, yeah, this is stage 4 cancer. Did nobody tell you that this is stage 4 cancer? Rob and I burst into tears. Like, I've never burst into tears before. I burst into tears in his office. He mentioned it so casually in conversation, like he was asking me if I wanted cheese on my hamburger. He was like, yeah, stage 4 cancer, it happens all the time. I was like, like nobody staged me in my original doctor's appointment. And so I got that news, and I think I was in shock, and I was like, of course I'm asking questions, and I'm like, stage 4. I was like, how is this stage 4? I'm like, that's like end stage. Like there's no more higher stages than stage 4. I'm like, what are you even talking about right now? I was like, what is my life expectancy? And he's like, well, we've seen people live anywhere from, 3 to 6 years. I'm like, 6 years? I was like, are you trying to tell me that I'm not going to live to see 40 right now? Like I was going through it in his office. And I just remember, I just remember feeling like, what the hell did I do? Like, how is it that, how?
Yeah.
Like I didn't even smoke. I never did hard drugs. I really lived a straight and narrow life. So I'm like, I don't understand what I did and why all of a sudden now this is my story. So with my lung cancer, I have ALK positive mutation. And so with the ALK positive mutation, there's no cure. It's just treated and it's managed. And so I take 4 pills in the morning and 4 pills at night. And it basically keeps everything at bay. It's gotten rid of any other extra areas. I had some few areas in my lymph nodes that went away. I had one that was down by my liver, that's all gone. All the tumors that were in my upper, back area are all gone. And the only thing that's left right now is just the main tumor on my left lung. And so that is my prognosis. I just take this medication until my body eventually develops tolerance for it. And then I'll be put onto whatever the next line of medication is that's, the next newest thing on the market. Yeah. And so the way I find out if it's working is I either develop more fluid in my lungs again, or I start to get back pain, or I start to feel like I felt before I started taking the medication. And so the scans help to determine if the medication is still working.
You've been through so much, and everything we've talked about thus far, details a lot of that. How are you feeling now?
I feel normal. Is that weird? Like I almost forget to take medication sometimes. The doctor said that this would happen. The doctor said there would be a point where I felt like there was nothing wrong. And I'm grateful. That's another reason why I'm grateful. I actually can actively forget that I have this sometimes. There are times where I can go through my day and just be like, oh shoot, yeah, I do have cancer. Damn. Like, I know there are people who don't have that luxury. There are people who are reminded every day, every second, and there are people who are, you know, living their last days with it, you know, and they're very much aware of what's happening. And so I'm grateful that I have the opportunity to even be in the space to forget that you know, I'm dealing with what I'm dealing with. And I mean, honestly, I'm just like, and I hate to say that too. Like, that's one thing I hardly ever say, because I realize how privileged that sounds. And that's never my intention to sound privileged, you know, especially in regards to what I have going on. It's merely just to reiterate how grateful I am for my path that I walk. You know, it is not to downplay anybody else's journey, anybody else's walk that they're on, because I realize this is tough. And, you know, we all have our different paths to walk. And I never want to take away from anybody's story, anybody's journey, or to diminish anybody's walk at all. So that's never my intention. It's really just to tell how grateful I am for where I am. I almost feel like I can do this.
If you're watching this and resonating with any of this, we want you to know that you're not in this alone, that you're never in this alone. Until next time, sending love.
Until next time, sending love.
If any of this has been helpful for you, we welcome you to go ahead and to click the like and subscribe buttons. If you'd like to join us for a candid discussion about your experience with chronic illness, or if you'd like to connect to simply say hello, we welcome you to reach out through any of the social media platforms or through our website, and all of our information is listed below.
journey about lung cancer and lung cancer treatment. I want to remind everybody, again, everyone has filled out their pre-survey, and you know what comes after pre-survey? Post-survey. So if you haven't done it online, please do so in here. In the back of your packet, there is the post-survey, so at the end of this, please go ahead and fill that out. It kind of guides us as to how things are going and where we're meeting our target appropriately. We're going to have a nice little panel here. We're going to talk about navigation, support, survivorship, and we're going to ask each one of our panelists to kind of describe how they go as far as their journey. So as I call you out, why don't each of you come on up and have a seat. We're going to start off with Dr. Isidore Arzu. Dr. Arzu is a graduate of the University of Texas Medical Branch at Galveston, and then she completed a residency in radiation oncology at the University of Texas MD Anderson Cancer Center. Dr. Arzu is a practicing radiologist. She is a professor at the University of Texas MD Anderson Cancer Center, and she's in the Division of Radiation Oncology at the MD Anderson Cancer Center. Our second panelist is Ms. Dana Thomas. Ms. Thomas, why don't you come on up, have a seat. She is the coordinator of lung screening program with the Grady Health System. She is a graduate where she got her BSN at Clayton State University, then obtained a Master of Science in Nursing Practitioner at the University of Alabama in Birmingham. She's certified in adult gerontology, primary care and nurse practitioner, and again, she is the coordinator with the lung screening program at Grady Hospital in Atlanta. Our third panelist, Ms. Griffin, if you would please come up, is Ashley Griffin. She is an oncology social worker. Ms. Griffin obtained her Bachelor of Science in Human Development and Family Studies at Colorado State University in Fort Collins, Colorado. She denies it, but I think she went down to Louisiana to warm up after being up there in Colorado. You can say all you want to, but I know, we all know, where she obtained her Master's of Social Work at Louisiana State University in Baton Rouge, Louisiana. She is a licensed master social worker and works at the Texas Oncology Houston Medical Center. Welcome to you all. I think before we take some questions, let's start off because we're talking about how people navigate this whole process. Dr. Arzu, you're kind of at the tail end of things. Tell me, what is it like, because earlier today we had a nice discussion by Roxy Hall Williamson, forgive me for not saying the whole name, Roxy, about what it was like for her as the patient. But when you see that patient, what is that? Tell us about what that looks like.
Well, as you already said, we're like the ultimate specialists in radiation oncology. So by the time the patient gets to us, they've already been diagnosed. Most often, they've already seen a surgeon. They've already seen a medical oncologist. And at MD Anderson, we have a tumor board or multidisciplinary care. So each new patient to the thoracic center is presented to the multidisciplinary team. And that's where they will come up with a plan for that patient. So obviously the patients are put into two really big boxes. That boxes will be surgical versus non-surgical, curative versus palliative. And so that will, whichever box they fit into, will drive their treatment. For lung cancer, in general, the best cure is really to be able to have surgery. But if patients are long-term smokers, for instance, they don't have the lung capacity or the heart to be able to tolerate a surgery, so then they will come to us to get radiation therapy with chemotherapy oftentimes. If they're too weak for chemotherapy, like I saw a patient on Friday, he was in a wheelchair, they won't give him chemotherapy, so he comes to us for just radiation therapy, and usually that's palliative. As far as it comes to access, I mean, as you all who live in Texas know, MD Anderson is a public hospital. It's one of two that belong to the state of Texas. We're one, and UTMB Galveston is the other. But MD Anderson really and truly operates like a private institution, so you really have to have insurance to be able to go there. If you live within Harris County, you can have access to Ben Taub, which has radiation services as well, and they also have medical oncology services for patients to be able to get chemotherapy. Before the pandemic, we used to have a clinic that will help people apply for Medicaid if they're indigent. I don't know if that service still exists because I work in Sugar Land, and the patients that come to us have already been screened for their ability to pay. But in this country, generally speaking, as you already know, cancer care is exceedingly expensive, and it's really a financial burden to the family, especially if those patients don't qualify for Medicare, or if they do have Medicare, they don't have a supplemental insurance, and you're responsible for 20% of that fee. Radiation itself can be quite costly, and so those patients end up with, being in debt. There isn't much services really within the institution to help the patients with, like, a gas bill or a light bill. Those patients really have to depend on their family or from community help of some sort, some program that will be able to help them navigate the cost of actually getting care. As far as the African American community is concerned, in my experience, I think that as a percentage of our population, we have fewer people that actually smoke, but unfortunately by the time they get to my door, it's usually pretty advanced because oftentimes they don't have access to screening. So if we know that patients are long-term smokers, they can have a high-resolution, non-contrasted CT scan that can pick up early-stage lung cancers, but oftentimes the patients aren't screened at all. So oftentimes, by the time they come to see me, they have pretty advanced disease. When I started out in 1999 as a resident at MD Anderson, to today, we're talking about 2023, there are lots of new medications and drugs out that have really been, I think, life-changing for patients who are diagnosed with lung cancer, especially when they do all the different markers that the patients may be able to benefit from these new medications. The new medications aren't cheap, but they're very helpful in terms of prolonging life.
Well, thank you very much. And we'll come back to that in a few minutes after we have our question and answer, because you brought up a lot of good points for us to talk about. Ms. Thomas, one of the things that we heard a lot in one of the earlier sessions, and we've had several people online even question, is what about who is really a candidate for getting screening for lung cancer? One of them, can they themselves just refer themselves for this? And two, as we heard in our previous discussion, what are the real criteria, and are these hard and fast rules? How do you all handle that?
So as far as guidelines, what insurance will pay for, because that is a concern. So when we talk about screening, we talk about no copay. That's the biggest thing patients ask. Will I have a copay? If it's a screening that is per guidelines, meaning you're between the ages of 50 to 80, and you meet the pack year criteria, which is smoking a pack a day for 20 years, or about 2 packs for 10 years, and if you quit smoking, it has to be within the 15 years for you to qualify. And you also exhibit no symptoms, no persistent cough, no coughing up, blood, no persistent chest pain, because we're doing this when you have no symptoms. A lot of people are, oh, well, why should I do it? Because I feel fine. It's screening, just like with breast cancer. You don't have any lumps, but it's to prevent, for us to find it early. So when you meet that criteria, you will have no copay when you go for this CAT scan that's ordered. So that's the important part to remember. If you ask for your doctor to order this outside of guidelines, you will be required to pay, cash pay. Self-pay. It's not following the guidelines. It's outside of what all the tests and studies that they found that you're not high risk. Even though lung cancer can happen with anybody, non-smokers, we're focusing on the high risk, and that's what insurance will pay for right now. Those that are more high risk for developing lung cancer.
Thank you very much. Ms. Griffin, again, in our last session, there was this question about navigating the system. The patient's diagnosed, simple things. How do I get back and forth for treatment? What are the resources that I need in order to help me cover the cost of treatment, or even, and what is out there for families? How do you support the people who are supporting the patient? Can you address some of these issues, please?
Yeah, so my role along this process is exactly that.
So it's kind of all those things that are not medical. I address barriers to care, and I would say that transportation is a big one. I get a lot of consults for transportation, which leads to other barriers, right? Like if transportation is an issue, there's usually a lot of other things that are also barriers to care. And as Dr. Azar said, is that especially with Medicare, if 80% that Medicare covers, then families are still required to cover 20 if they don't have some kind of supplement. So then it becomes, do I get my cancer care or do I pay my bills? And so what that looks like is, for example, at Texas Oncology, we have a small transportation grant through the American Cancer Society where I can do Lyft rides. A lot of times I try to tap into insurance or problem solve with families of, okay, sometimes it's hard, when you've spent your whole life kind of taking care of things. If you needed something, a bill paid, you went out, you figured out how to do it. But cancer is unpredictable and just doesn't discriminate. And so sometimes that requires asking for help when it's not the easiest thing to do. And so sometimes my work is working with families to say, I know you don't want to ask, but who can we tap into and trying to see what those resources are. But there are a lot of community-based resources out there. But the thing is, a lot of them are national. So you have people from all over the country tapping into the same pot. So they go quick. And so that's my role, is to helping you navigate all of those things. I like to look at it as one of my hats is a bridge to resources. And so for families, sometimes I say, you do that part and let me take this. To just take something off the plate to see what I can find. And sometimes I can't, because resources, especially for adults with cancer, is very scarce.
I want to remind, for those of you who are joining us on the live stream or on Zoom, if you have a question, let us know, and I'll try to make sure we get to it. And for those of you here, please, if you have a question, raise your hand. Dr. Arzu, to this very point, to what degree does the patient's inability to get to the treatment and or have the resources, say, to eat or maintain their own health impact your treatment decisions and how they handle the treatment for their lung cancer?
Oh, well, I have to say that, in general, as physicians, we don't really get involved a lot of times with the patient's inability to get to our care. We have the social work department and patient advocacy. So everyone that comes to MD Anderson has a patient advocate to help them navigate those things. However, with their nutritional status, if they start losing weight, we do have a nutritionist, and that nutritionist will see that patient every week or more frequently if needed. And they will do things like, recommend feeding tube, ordering Boost and Ensure to be delivered to the patient's house, teaching the family how to use a feeding tube so that the patients can maintain their nutritional status. There are a couple, philanthropic groups within MD Anderson who raise funds among the employees, who give, gift cards to go to the cafeteria to eat, or to the nearby Chick-fil-A, or I think it's Burger King that's across the street, so that patients can.
You're talking to a colorectal surgeon about patients going eating at Burger King and stuff. We'll let that one slide for now.
Yes, this is true.
Okay.
However, not everybody can afford to, have, 2 vegetables and a roasted meat. So we have to, give what we're able to raise within our department, the gift cards to those patients. MD Anderson does have a small budget for transportation, but like this young lady says, the money goes quickly. So I think probably we're now in almost May, I think the money is probably done to help people get from South Texas, because we do get quite a few patients from the border who are U.S. citizens, but they live on the border with limited access to health care.
But to that degree, when we look at survival differences for African Americans versus others, doesn't the overall health of that patient coming into, it's one thing to come in with lung cancer, but it's another thing for that patient to come in with diabetes, hypertension, and or renal disease. So don't those other things impact negatively on how well they tolerate or perhaps successfully complete their therapy?
You have a point there. That's really very, very, very true. And for me, I think one of the biggest drivers to poor outcomes is obesity and diabetes. Because patients, I tell patients now to think about it this way. a lot of the new drugs that they are now developing work on to try to boost our immune system.
Yes.
If you're a diabetic and your sugar is out of control, for instance, we know that you can lose your toe, you can lose your foot, because your immune system is kind of drunk on sugar and it's not doing what it's supposed to do. So we need your sugar to be the best it can be, so that your own immune system can help you fight off this cancer. If your sugar is 300 and 400, you're going to end up spending most of your time in the ER unable to get the care that you need. If you're supposed to go to surgery, which is really the definitive care for patients who are surgical candidates for lung cancer, and your hemoglobin A1C is 11, and your sugar is out of control, no surgeon's going to take you to the operating theater. That's it. So, and we do know that chemotherapy and radiation therapy is really a second best, but if that's all we can offer you, if your sugar is out of control, then that's a problem.
One of you have a comment to make, please?
I think, to address your comment is that from my role, I see exactly how the social determinants of health, how a person's holistic picture impacts their ability to successfully do treatment. Looking at radiation specifically, sometimes my patients, they have to, 6 weeks every day. So if you have a lack of transportation and a lack of resources to get to radiation, that's going to take about 5-15 minutes, and it took you all of your resources to try to get there for that amount of time, it's a huge strain. That's when I get a lot of kind of compliance, so missed appointments, where, patients, whether it's gas or getting there, metro, when I'm tapping into all of these resources. For example, the American Cancer Society has a ride share program where volunteers will take patients to their appointments. But if there's no volunteers, you're not getting to an appointment. In the medical center, there's ground angels where, again, that's volunteer-based. Well, they'll take you to your appointments, but if there are no volunteers, then you can't get to your appointment. And so you see where when I'm doing a psychosocial assessment, I'm looking for all of these social determinants of health. I'm looking for who are the people in your life that support you, because cancer treatment is just as much as a mental game challenge as it is physically, and so you have to have people, you have to have support. If you don't have food in the house, that's another thing. So I'm looking at access to all of these areas of one person's life, because when you look at research of the impact of just the social determinants of health, a person's social life, that these also impact their cancer care and their survivorship, which is why social work is very important, and why a lot of our goal is to show that social work or these kind of support systems, patient navigators, are necessary for patient care, that it has to be in combination with them.
Fantastic, thank you. Dr. Fernell.
Yeah. Ms. Thomas, can you explain to us what the patient might expect when they undergo the screening? Is it a long part of their day, and the follow-up of the results?
When patients have their screening ordered, the first question they usually have is about being afraid. Is it going to hurt? Is it a tube? Because they always have that picture in their mind of the MRI being enclosed, not being able to breathe. So there's a lot of fear involved in getting the CAT scan, getting the screening, that low-dose CT scan. So I let them know when they show up for their appointment, they are on a schedule for their CAT scan, so they're on a schedule with other patients that are there for different reasons, different CAT scans. So once they get to the back, they're verified. The technician will go through their name, their date of birth, and they're in a huge room. So you're not enclosed, you're in a big room with a machine that's a big ring with a little table in the middle, able to lay down on a sheet, have a pillow, and we have a nice little fancy CAT scan that you get a little skylight, you're looking at clouds, they try to relax you, tell you to lay down, and once they pull you into that ring, which gives a dose of radiation, they'll scan your chest. That part takes about 4 or 5 minutes, just depending on how new. We have a new machine now, so I got completed in 4 minutes from the time they're laying down. So we have patients that are worried about laying flat because Like, I have 3 pillows at home. I can't lay flat, so I let them know that it's very quick. They're watching you. They can speak with you from the room to let you know if you have any discomfort, you need to sit up, just let them know. But the test itself, once you reach to the back, about 10 minutes, excluding your wait for your visit time. So it's very, very quick.
Okay, Ms. Thomas, I've shown up. I'm lying on this quick test, which I'm on my back looking up this fake sky.
Yep.
Okay. The test goes off. I am now freaked out because I just had some test done. I have no idea the result. I came in feeling fine, and all of a sudden I feel this magic machine is going to tell me there's something horrible that's going on in me. So how long does it take for me to get results? Do I get the results from you? Am I going to get the results from my primary care provider? And then what happens if there is something suspicious on this study?
So those results are sent to the ordering provider, and they're also sent with me, the screening coordinator. So we both see those results same day. If there's something very concerning, the radiologist has to contact that ordering provider. If it's something what we call long RADS 4, meaning something needs to be addressed in a short amount of time or immediate response. If they cannot reach that provider for any reason, we have our director, Dr. Flanaugh, actually works with me in Atlanta, Georgia, so they contact him as well. So we both have those results and make sure that the patient is informed, and the provider will let them know next steps. So we do have a lung nodule clinic, which I'm a provider and I work with Dr. Flanaugh, so those patients more than likely will be coming to see us. What we'll do, discuss their results in person, able to show them the imaging, and talk about next steps, what it would be like for you. We'll give you our recommendations, and then also let you decide based on different options what would be best for you, because we know it's just not easy to just tell you this is what you should do. There are a lot of factors going on. It might be your health status at the moment, social issues, other health problems that play a factor in what would be the best decision for you. So a lot of the patients, they do see us, they talk to me pre-screening because I'm explaining what happens with the screening. I'm the one calling them when they need an appointment for abnormal scan. But then I'm also involved when getting you to where you need as far as follow-up. Maybe back to your primary care provider or sent off to the oncology services.
All right, but as you and I both know, we'll come just a second, we'll come to you next. But you and I both know that a delay of 6 weeks is probably not going to have an impact one way or the other on the clinical outcome. But you and I both know that a delay of 6 hours is just going to drive the patient crazy. So what time frame has this wonderful scenario you just gave me, and by the way, I applaud you for how you all have that organized, but how long is this actually from that screening to when that patient sees Dr. Arzu or someone equivalent thereof?
So we give the providers a week to discuss the results with the patient directly. If I do not see any action within a week, I contact the patients. The patients also receive a letter with their results with my direct contact information. So if they have not heard anything, they have my direct contact information to discuss it with me directly.
Okay. Thank you. Yes, ma'am, you had a question. Please use the microphone. Allow me to help you up there.
My name is Summers, but okay. I came in today to do the screening. I don't know nothing about this, but I'm hearing y'all saying stuff. But I've been smoking for about 30 years, and I quit smoking. It's been a year. I quit smoking a year.
Congrats.
Okay, and I wanna get it done just to see if I have something wrong with me so they can catch it. But I don't know what to do because I have aphasia. I have aphasia.
That's, I tell you what, Ms. Griffin, you're local. What steps should she take to try to see? What's the first thing she needs to do and the second thing?
In terms of after.
Getting screened, no, to get screened, because she wants to get screened. So in terms of local resources here, then we'll get you to talk about nationally. What about locally? Is there anything that, what should she do? Okay, go ahead, Ms. Thomas.
I've been 30 years in, I even think about my sister and them. They got secondhand smoke. Everything that y'all been talking about, I'm listening to it, and I know that it's something wrong in that picture, and I need to get tested.
You're making the first step right now. Thank you.
Exactly.
So,
And
thank you for coming.
And there's always a lot of concern with patients. How do I bring it up to my physician? How do I bring it up to the provider? Because they feel if it's important, they'll bring it up to me. And a lot of the time, that's just not true. We know some providers just do not screen. That's something we're working to change. And, a lot of discussion, a lot of African Americans are not screened. The discussion is not even brought up when they go to the doctor. So, one of the things I like to focus on, a lot of the patients, they receive return screening letters when they're due for their annual screening, and they call me and they ask me, can you talk to my provider for me? Can you let them know that I'm interested? And I tell them no. Because, the goal is to empower the patient. I want you to be open. I want you to feel that you can. This is your health. This is your well-being. I want you to open that conversation. If it's not brought to you, bring it to them. I tell them, bring that letter. If you don't know what to say, bring it to them. Let them read the letter. And let them start that conversation if you don't quite know what to say. But you did a great job. You start that conversation with us, talking about your smoking. So that's just what you need to do. Just start the conversation with your provider and let them know that you're open to screening and that you want it done.
Dr. Arzu, you wanted to make a comment on that?
At MD Anderson, there's a cancer prevention clinic, and you can always call them because they do have screening at all the different centers that ring the city, including one of the medical centers. So the one at the medical center will probably be the closest to this church if you live nearby. And so you can always call that number and say that you've been a long-term smoker and you want to participate in, you've quit and you want to participate in the cancer screening program, and they will get you an appointment. It's called cancer prevention. Just call the main MD Anderson number and ask for cancer prevention.
So before you leave, either Dr. Arzu
or you can, or I can give you my contact information. You can call me directly.
Yes, ma'am, please.
Dr. Arzu, you were talking about indigent care. I'm familiar with several people, one in particular, that her care was postponed after she was diagnosed for about 6 months until they could work through. She has gone on, transitioned. When that was because she didn't have, well, she was indigent, so she didn't have all of the resources that some of us in this room do have. My daughter had aphasia, and immediately when they discovered that she had a mass on her brain, literally within a week we were in Anderson, within a week. But we had insurance. She was covered. So she got the top tier in terms of how quickly we got everything taken care of. I know Summer, and she attends the same program that my daughter attends. So some of the things that she has mentioned in terms of trying to navigate, it's not as easy for her as it would be for some of us in this room. I do intend to talk with her as well afterwards because she and my daughter attend the same program. But I was wondering, all of you represent 3 different areas of care. and all of you represent 3 different institutions. Are all of the institutions programmed the same way? I see you, and then I'll see you next, and I'll see you next. Or are we just getting what would I call it? The best of the, right.
Creme de la creme, yes.
Creme de la creme. That's what I want to know.
Well, in Houston, indigent care, you do have some options because there are the city, Harris County Hospital District, so there's LBJ and there's Bentab. And if you live within Harris County, you can get a Harris County Gold Card. And then that will give you the ability to access cancer care either at Bentab or at LBJ. So MD Anderson, I know for breast, well, no, that's not true. For medical oncology at LBJ is run by MD Anderson's fellows, and a couple of the attendings are there monitoring that care. I'm not sure exactly what happens at Bentab because I've never worked there. Other than that, like I said, if you can apply for Medicaid, there was a office that will help you do that. I know that Texas does have a program for breast cancer and cervix cancer, and those patients would qualify for Medicaid. It does not have the same services for other types of cancers, just breast and cervix. But one disadvantage of being in Texas is that we are one of the few states that did not expand Medicaid for everyone. And so therefore, a lot of people are left without any kind of coverage. Most people kind of apply for Obamacare, but that also requires a certain amount of knowledge in terms of how to go about doing that, as opposed to just being able to apply for Medicaid if you are indigent. But the indigent can go to Harris County. If you're undocumented, and we have a very large population of undocumented people, then all bets are off.
Ms. Griffin, would you address that? Because I think Dr. Ozu brought a couple of interesting points up there.
Yeah.
So how did we go about navigating that?
Mm-hmm. So, yes, if you don't have insurance, in Harris County, there's the Gold Card, but then that limits where you go. A big thing is, for example, MD Anderson doesn't take the Obamacare, so that's, and also a lot of Medicaid programs, MD Anderson won't take. And so it kind of limits you a little bit on what you have. And so, in terms of insurance, yes, there's that. And like Texas Oncology, it's a community-based organization, which, we do take those, sorry, my phone's vibrating. Those insurance, like, vibrating on my back. And so it does take those, but insurance becomes a big thing, especially because if you do have a marketplace plan, then there's going to be co-pays with that. If you have SSI, of course, it's a fixed income. So now a lot of your income is going towards paying the premium on your marketplace, your marketplace plan, which again is limiting just care. It just becomes this big a trap, really, of that, not being able to have the resources. I was thinking of another one. Yes, there's the breast cancer, but if you don't have breast cancer or cervical cancer, it's very hard to get Medicaid in Texas if you're not a woman with children. Some patients I have, if you do already have a diagnosed cancer, you can do SSI disability, which if you're applying for a medical disability, so there are already some cancer diagnoses that are considered what's called a compassion allowance. So SSI, the Social Security Administration, already considers those to be a medical disability. Depending on the staging, then it can move very quickly. So it's not that 240 months that you're waiting for an SSI determination, but that does tack on there, which can come with a supplement of Medicaid. And for me, a lot of my patients with lung cancer, they're already stage 4. So they can do the Medicaid, the Medicare, we can do the compassionate, the SSI.
But in the answer will take Obamacare if you have one of those gold-plated platinum.
Yeah.
It has to be just trying to get Obamacare and pay $5 a month, you can forget it.
Yeah,
Yeah.
I think
And they do not take Medicare Medicaid capitated plans. They don't take those Medicaid capitated.
One of the things you hear of interest as a recurring theme, we talk about how important it is for the patient to be their own advocate. I will harp upon what Ms. Roxy Hall Williamson said, how we have to push. But don't forget, it begins sometimes with voting.
Exactly.
Sometimes that one vote can make a big difference. You talk about advocating for your health plan. How many times have we heard about the absence of an expanded Medicaid, absence of the Affordable Care Act being implemented here, talk about absence of coverage for screening? Vote, 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 vote. Dr. Arzu, I love to pick on you people in radiation oncology. You know, Ms. Thomas has gone through all this wonderful stuff. They've had this wonderful conference where everybody's talked. So the patient comes in there to see you. You've talked to them. There's 15 people around the patient in this room. Suddenly, everybody leaves. And then everybody comes back in again. Where'd everybody go? And what's happening when all those people left?
That doesn't happen as much for lung cancer patients, but it does happen for breast cancer patients because you have to talk about the type of surgery, your options.
I'm talking about the treatment, during the treatment time. That's what I'm talking about.
Oh, during
when
the
you actually,
treatment
yeah, that's it. 'Cause, you know, everybody comes in there and fiddling around with the patient. They're on the table.
Oh, you're talking about the therapist.
Yeah, when they're actually getting the actual therapy. So what's going on and how does that work?
Okay. Well, if the patient was prescribed radiation therapy in the multidisciplinary conference, they come to see me. The first thing that happens is we have a consultation. This is what's going to happen. I tell them all the side effects, and they have to sign a consent. Then they will have a planning session, and that's where we use a high-resolution, fast-speed CAT scan and to plan their radiation therapy. So we use the CAT scan, we compare it with their PET scan to make a plan for where we're going to aim the beam for the radiation. Then they'll come back usually a week later because at MD Anderson, everybody has to go through a quality assurance process. So the physicist has to be able to do his job. The people who make the plan call a dosimetrist, they got to do their job. And then, we have to present the case to the team, meaning all the people who treat thoracic get together and look at the plan and say, okay, I think that's a great plan for this patient based on his imaging and the pathology, his or her. And then they come for their treatment. So what happens when everybody goes into the room is to make sure the patient is straight, the patient is in the position in which we did the radiation treatment planning. They will also rotate the machine around the patient to make sure that the machine doesn't collide with their arms, for instance. They'll take images, and then they'll send those images to me so that I can compare those images taken that day to the image that we took when they first came for their planning session. So everybody has to leave the room because no one is allowed to stay in the room while radiation is being delivered. And then when the treatment is over, the patient gets up, gets dressed, and go home. The treatment itself is not very long, as Ms. Griffith has already said, probably 15 or 20 minutes, unless it's something that's really, really sophisticated. For instance, if a patient is not a surgical candidate and has a small nodule in the lung that has been biopsy proven to be positive, then those patients will probably get 4 radiation treatments, and that's really high doses of radiation. So they will be on the table for about 45 minutes because the physicist has to come look at the image, I have to go look at the image, everybody has to agree that this is where it's supposed to be, and then the patient can get treated.
We understand what happens surgically. You're actually cutting something out and removing it. But give us, if you can, the thumbnail sketch. How does radiation kill the cancer cell?
Well, that's a really great question. So what I tell patients, I usually start with, okay, so let me explain to you my cartoon of what cancer is. So cancer are cells that I say have lost their social graces. They continue to grow even though they have a neighbor. So when you're in utero, for instance, you get a mass. This mass knows that it's supposed to be a nose. And so the cells in between that make your nostril will die off. So it's supposed to have a mass. But when you're fully formed and you have a lung cancer, a mass is not supposed to be in your lung. It also can mask itself so that your immune system doesn't say, oh, this is a danger to my life, destroy it, repurpose the ingredients, and then you don't even know that something has happened to you because your immune system is on it. So when you develop cancer, the cancer grows over its neighbor, even though it's not supposed to, because generally speaking, our cells in our body in cartoon is like sheets, and they have maybe layers where they're supposed to have layers. But then they don't die because they're cancerous, right? while your normal cells would normally die off. So when we give it radiation, what happens is that high energy radiation beams go in and destroy or damage the DNA. So when they try to make daughter cells and granddaughter cells, they can't because their DNA is damaged. Radiation will also affect normal cells, but normal cells are normal. There's nothing wrong with them. So cancerous cells have an impaired mechanism to repair, so they will preferentially die off because their DNA has been damaged. Cancer cells also don't recognize where they're supposed to be. So my favorite example is that one morning I was getting ready to go to work, and Robin Roberts, you know, the lady on ABC, CBA? ABC, yes, who had cancer, had a complication from chemotherapy. So she needed a bone marrow transplant. So her sister gave bone marrow from her hip. So the morning I was getting ready to go to work, there was Robin Roberts with her arm out and her doctor giving her an infusion of her sister's bone marrow in her arm. So because the bone marrow cells that her sister gave are normal, they immediately home back to the bone marrow and repopulate the bone marrow so that she would have, you know, normal life like everybody else because they're normal. So cancer cells they don't recognize where they're supposed to be, so then they start to travel. And this is the reason why patients with lung cancer end up with cancer in their liver. It's not liver cancer, it's that lung cancer that didn't remember it's supposed to be in the lung, travel to the liver, and then set up shop there. Or they set up shop in the bones, or they set up shop in the brain, or wherever they set up shop. That's what. So radiation, what it does is damages the DNA to prevent them from making more cells. So then they die off, and then when the patient comes back and they have a PET scan or a CT scan or whatever, and they tell them, oh, your tumor has shrunk considerably after radiation because the cancer cells have now died off, and your normal cells repair themselves and go on.
Ms. Griffin, Ms. Thomas, either one, please. Internet is a wonderful thing. There's a lot of wonderful things on there with cats doing things and dogs and all this, plus healthcare information. What is the danger of going online and getting information? And can you recommend and tell us how we can tell us a good site and tell us some good sites where we may go? Whichever one wants to start first.
Our patients always trust Dr. Google before they trust their providers. You know, I try to stress to the patients, be open-minded, because a lot of times when we're giving the patient their diagnosis, they're already having in their minds what they're not going to do. They won't tell me what they will do, but they tell me what they're not going to do. They'll say, you know, I had an aunt that had chemo. She didn't do well. I'm not going to take chemo. You know, I'm not going to go see the surgeon. Once you start cutting, they're going to spread the cancer. It's going to go everywhere. So I definitely don't even want to speak to the surgeon. Oh, radiation? Oh, I heard that once you radiate me, you know, things are just not going to go well. So I tell patients, you know, ask your providers at least be open to a consultation. You know, at that visit, they're not going to do anything to you. They're simply going to give you the information that you need to make the best decision. You know, we want to educate you, and then from there, you can take that information and decide what's best for you. But I tell them at least be open to that first visit. You know, when we set up our patient for oncology appointments, I let them know that it is going to be a long visit. You know, the medical oncologist is going to come in. You know, they usually have a fellow, so you meet the fellow. You meet their radiation oncologist. They probably have a fellow too. You're going to meet that person. You're going to meet the nurse navigator. You know, she's going to help you throughout the scope. If you have questions, need to reschedule appointments, you know, contact her. You're going to meet the social worker. If you have questions about transportation, applying for cancer state aid, FMLA paperwork. Then you're going to meet the nutritionist. Nutritionist is going to come in and let you know, if you're having difficulty with, food access resources. You need supplements, they'll talk to you. So there'll be a lot of people engaged in your team that are going to help, you along the process. So I let them know, at least be open to the information. Instead of Googling and taking the bits and pieces from everywhere, at least go to the visit and get that education and that information firsthand as it relates to you. Because they have that information about your health care, your past medical history, your family history. So they're making and giving recommendation based on you. And not, when you Google, you'll have the cases you read out there,
They're like the worst cases.
they're the worst. So you don't want to go off of that. You want to go meet with those experts that can tell you based on, your health, your history, your results. That's the best way to get that information.
Ms. Griffin.
So you guys just heard the whole process from Ms. Thomas. And that process is why in my role, even when I see patients at the end of treatment, even in survivorship, why they are still just have like survivor's trauma, because it's a lot. Cancer is already a loaded word that comes with so many things where, just hearing it. I also do therapy for our patients, and one patient, she told me, she said, the hardest call you can make is to an oncologist because it's so loaded about what that means. And I believe that in communities of color that we're starting many, many steps back, right? When it comes to that, there's historical distrust with the medical system. And so then, we're not getting those preventative screenings, going for those annual well checks. If something's wrong, we kind of just, I have, my mother-in-law says, take some milk of magnesia. I'm like, I don't think that fixed everything, but it's like we're coming to things a little bit late, like when we're getting to the, of the party. And then the language sounds like a foreign language. Sometimes when I was at Texas Children's Hospital, I worked with in our oncology department there, but we would sit in the diagnostic talks because there's so much being said, as Ms. Thomas mentioned, where I'm sometimes taking notes for the patient of, okay, this is what they said. So if you are going to any screenings, if you are going to your first appointment, take someone with you, because building a relationship with your provider, it takes time to establish that trust. I give another example of a patient that I recently had. She has lung cancer. She's not Black, but what she is that she doesn't trust her provider right now because she's like, why are they not telling me this? But it's because sometimes it's just misunderstanding of, okay, well, how do I understand all the things that you're telling me? And the fear that's associated with just cancer and cancer treatment can mask the whole process, and that's why I think having support is so important, to be able to have someone where you can say, I don't understand what that means, because when you hear that you have cancer and that you need treatment, you just go to survival mode, and that's also very like trauma. It's, okay, I got to get radiation, I have to get this, and you just do all of those things. And then, you're sitting on tables and people are prodding and they're putting it in a port and they're doing all these things and you're kind of just laying there going through it all. And so when I find, and I'm talking to people who have finished treatment, they have increased depression, increased anger, increased all these things. And they're like, why am I feeling this after treatment? It's because you kind of just survived going through all those things. And then when you're done, you're like, well, what in the world did I just go through? And that's the same thing for caregivers and families, because a lot of times in the families, the roles switch. Or now you have children taking care of their parents and all of these things that are you didn't plan for. And I think that cancer is, it's just, I say, unpredictable, as you said. It doesn't follow any order. And so our lives sometimes have to adjust, and that's hard because it's an out of control situation.
Dr. Ozu, I'm going to give you the last word, but first I must remember Harry Belafonte, who just passed, and he had the song, There's a Hole in the Roof, Dear Henry, which goes on about the hole in the bucket. Point being, of course, if you recognize when there's a hole in the roof and we fix it, the house can be saved and the structure is sound. But if we don't and the water comes rushing in, the house can be destroyed, and the cost of fixing it is going to be exorbitant if we can even do this. So tell me, if we do our screening, so we got good old Ms. Thomas has got us into our screening program, and we find an early lesion in the patient's lung, and Ms. Griffin can get us there for whatever the treatment is, for early stage lung disease that we can catch by screening. Are we winning the battle there, or are we just treading water?
No, I think we're winning the battle there. If the patient can have surgery, I would always recommend that they go to surgery. The second best would be radiation therapy, and unfortunately, because usually those patients have smoked, All I can say is that if you have a small lesion, less than 2 centimeters or less than about an inch, radiation therapy can take care of those, and they probably have a 90–95% local control. But oftentimes those patients die from something else, emphysema, heart disease, because they have smoked. Well, what we're seeing now is fewer and fewer cases of small cell. Dr. Floyd can attest to that, because fewer people are smoking. But the tobacco company isn't stupid, so they're selling their cigarettes outside the United States. And so I'm sure that we'll see a rise in lung cancer outside the United States compared to here in the United States. We're seeing more women. Before, it used to be, when I first started this journey, it was mostly men. But we're seeing more women because, we've come a long way, baby, but we also smoke too. So, but we're coming a long way on the wrong side. And so we're seeing more women we're seeing more people who have been exposed to secondhand smoke and they've never smoked. Those people tend to have a better prognosis than those people who smoke because their lungs aren't as degraded. And when I see people and they're still smoking and they're like, well, I don't need to quit now because I've been smoking for 30 years. I said, well, maybe you won't develop cancer, but you will continue to degrade your lung. And then the problem is having emphysema, and there's nothing worse than not being able to breathe. So I tell people, if they can, to quit smoking. But the tobacco company, I think if you go through some of our neighborhoods where we mostly live, you'll see a lot more advertisements for cigarette because they're trying to get us to smoke because we smoke at a lower rate than our non-African-American counterparts. If we buy our own magazines, I don't know if they still exist, like Ebony and Essence, I don't know if they still exist, in paper copy. There was a lot of advertisements in those magazines for tobacco use, while it's decreasing in terms of advertisements in the greater community in which we live.
Well, if you please all join me, give a hand to our panel. I think it's wonderful. And I would like to thank for those of you here with us at PMBC, thank you for being with us. And for those of you online also, thank you. And if you have more questions, we want to encourage you again to fill out that post-survey. And also thanks again to the wonderful IT and audiovisual group here at PMBC. And I must admit, I applaud them for their prescient ability to find out what Dr. Aruz was going to wear so that that microphone matched perfectly her dress. I'm just so astounded how you guys did that. I just want to compliment you. Pastor Jefferson, thank you very much. You have a wonderful facility. Your group has just been great. And thank you very much for hosting us. Please, sir, if you will summarize some things from your perspective and come up here. And you guys can go ahead and step down. And again, if you haven't been screened, get screened. If your family members need to get screened, take them. Women, you are the most important people in the world. Get everybody in the family screened. Pastor, thank you.
We want to thank again the Health of the Hill collaboration group, Sister Phillips, and all of those who have made this possible. I just believe that somebody's life will be saved as a result of what has occurred today and the information that has been shared. Don't forget to fill out the surveys. We cannot emphasize enough the importance of you filling out those post-surveys, post-symposium surveys, so that we can, the HEAL collaborators can have your information so that they can make a proper assessment of the effectiveness of our time together today, and to also help them with their future engagements. But we want to thank them again for their participation with us and choosing us to host this very informative. I have had my eyes open today as a result of what we have experienced and what we have heard. Doc, you have been just magnificent with your questioning, and our panels have also been so enlightening and informative. It's just been a blessing to be a part of what we have had the privilege today to witness and to share. Now, on May the 6th, we will have the next part 2 of this conference. And I'm asking all of you who are here today to be missionaries, to enlist the rest of us to come and see and hear what we have heard today. If you missed today, you missed some information that could have saved your life. And if you missed today, you missed some information that could have saved someone's life who you love. We need to be serious about this health concern with our lungs and with our whole body. And that's one of the things I want to also say, that the Health Collaborative does not just do lung cancer. They're for all whole body concerns with our health and our community. And so we are thankful to be able to partner with them in this critical issue. We are missing at the table of participation when it comes to health care. And for some of the reasons, they're structural. We don't have access to health care insurance. We don't have access through transportation. So there are things that we can do. One of the things that we emphasize here as we summarize up is the importance of not only insurance companies, but also our legislative partners. We need, right now in the state legislature, there is a bill being introduced by our state representatives for making it possible for us to have legally access to this biomarker testing. So we're asking all of those who are in the sound of our voice, and we will be working with our political partners to be sure that this legislation gets passed. It's important to the health of our community, and we want to be sure that we have access to what we need to be healthy. Lisa, I want to thank Dr. Watson for his participation this morning and for his hospitality. And it has just been so enlightening today. Thank you again, Dr. Phillips, all of those, the Health Collaborative that have been working with us. And we pray that on next Saturday, glad to see Reverend Leon Jackson with us this morning also. He just came in. He'll be standing with us on next Saturday for the part 2 of this symposium. I think that's all, Ms. Phillips. Did I leave out anything? She's my minder today to keep me online. She wrote my little cheat sheet out, all the stuff I was supposed to do. I want to be sure I got it all done. All right. I don't think I missed anything. I want to thank again the Amgen group for the sponsoring of this symposium. They are the ones who helped make this possible financially. Can't have anything today without some finance involved. But we also want to thank, this is one of the reasons I was so thankful for Brother Watson, Deacon Watson. He's a former Georgia legislator, and so he knows about the legislative process and what it takes to make this available to our constituents so that they can have the opportunity to get the best health care that they can possibly access. So if there's nothing else, thank you again for coming. pray that you'll continue to work with us to make next week more successful than today, so that we can be sure that we get this information into the right hands and into the right hearts and minds of those who need it most. All right? If nothing else, we will stand, have our closing prayer. Gracious Father, we thank you today for this another day's journey. That, Father, we are so glad today because by grace we have had opportunity to receive information that can save our lives and make us more productive in our business of taking care of your business. And Father, we thank you so much for those who have sacrificed and those who are serving in this vital area and this vital concern and interest that affects our community in so many ways. We pray, Lord, for the continued success of their efforts, so that, Father, the blessing that can be afforded by your enabling of them can be experienced by those who are the focus of your love and concern. And we thank you, Father, and we pray for those who will be traveling, that, Lord, you would give them traveling grace and arrival mercy. And for those who have served as on our panels today, Lord, that you would continue to strengthen them with might, and, Lord, help them to continue to do the things that they are doing to help our community and to further, again, the outcomes that we desire for our people. This prayer we pray in Jesus' name. Amen. Amen. God bless you all. Thank you so much.
And we are back with more of What's Now, taking our attention to health and wellness, especially lung cancer. I recently spoke with two individuals who have had lung cancer and very different experiences and journeys, and they have some great insight. Let's take a look.
You've been diagnosed with lung cancer, so what now? What do you need to ask? Where can you go? And how can you find the newest treatment options? Unfortunately, lung cancer is a leading cause of death among Black Americans, and here to talk more about this is Dr. Sydney Barnes and Brandy Bryant, both lung cancer survivors. Thank you both for being here today.
Thank you for having us.
Thank you.
Dr. Barnes, let's start with you. You are a lung cancer patient and a doctor. Tell us about your story.
I noticed when I started residency that my exercise tolerance was diminishing. I was becoming more short of breath. I am normally a very active person. I dance, swim, run track, and I realized that I was just getting more and more short of breath, and then I started wheezing. Now, I do have a very strong family history of asthma, so I thought that was what was going on, but I decided to go to a pulmonologist to get checked out. And after a whirlwind of tests, actually got diagnosed with stage 4 lung cancer, which was completely shocking to me because I have no risk factors for lung cancer. Thankfully, they sent my tumor off for biomarkers, and I was found to have a biomarker, so I started on targeted therapy, and I was able to complete my residency working 80-hour weeks and continue working and living a very normal life. And now I'm no evidence of disease 5 years after the fact, which is amazing.
That is amazing. Brandy, you're also a lung cancer patient, and you're doing very well on targeted therapy because you found out about your biomarker. Tell us about that.
So my story is similar to Dr. Barnett's. I was 39 years old, very busy mom of 4. I had a tiny cough for months that I didn't think anything of. It was really quite minor. But and I was active. I like to take long walks, walking like 25 miles a week. But after the walks, I noticed shortness of breath when I was just having conversations. So that prompted me to go to the doctor. After a series of tests, I was diagnosed with stage 3B lung cancer. I was initially diagnosed at a local community hospital, but I was very fortunate that they did send my tumor off for biomarker testing. I had no idea what that meant. And I still had to, because I was stage 3 when I was initially diagnosed, I had to do chemo and radiation. However, when I progressed a few months or just 2 months later, I had the choice of doing immunotherapy or targeted therapy. But because I knew what my biomarker was, ALK positive, I knew to choose targeted therapy because immunotherapy doesn't work well for ALK and a lot of biomarker-driven cancers. But it's definitely made things much better for me. I had my youngest kid was 3. I couldn't climb the stairs. I couldn't do anything. And once I started taking the targeted therapy, I felt markedly better within just a couple of weeks. Like the fluid was draining from my heart. Everything was feeling better. And I've been no evidence of disease since 2018.
Dr. Barnett, tell us exactly what a biomarker is and why patients need to ask their doctors about them.
So each cancer is unique, and some cancers have mutations that are driving the cancer to progress. And that is what the biomarker is. A biomarker is a mutation that is driving this cancer. There are many different biomarkers such as EGFR, KRAS, ROS1. Brandy and I are both ALK positive, so our mutation is ALK. And what a targeted therapy is, it literally zooms in on that mutation and turns the mutation off. It's so much better tolerated than chemotherapy and radiation therapy. It actually works much better for these mutations than the chemotherapy. And because of that, a lot of patients are able to lead pretty normal lives with it, which I think is one of the reasons why research is just so important. Had we been diagnosed 10, 15 years ago, we wouldn't be here. And now we need to know what further therapies are out there and what reasons people are getting cancer so that we can potentially save more lives.
Brandy, would it have made a difference in your treatment and in your quality of life if you had known your biomarker earlier?
I was fortunate to know my biomarker earlier. I just did not qualify for the treatment at the stage. At that time, I didn't qualify for the treatment at the stage that I was initially diagnosed, but it definitely made a difference whenever I progressed to stage 4. Knowing that I had that biomarker gave me a treatment that actually saved my life because immunotherapy does not work. It actually it has the opposite effect on ALK positive and some other biomarker driven cancers. So without that, I wouldn't be here today. So biomarker testing was extremely important and is if you're newly diagnosed.
And Dr. Barnett, how can people be screened for lung cancer and who should be screened?
I told you how many times I get a call back, I just.